Good morning, everyone. A very good morning to all of you, and I once again welcome you all to the live webinar with Professor Chintamani, a world-renowned surgeon and an exceptional and a very passionate teacher. So before we begin, I want to know if you can all hear us and you can hear me and you can see me. Please write a yes in the chat box so that we can know and we can proceed. Yes. So yes, after the tremendous success of the previous webinar, a lot of you wrote on the in the group regarding various uh, queries of common scenarios in the ward, and therefore then Sir decided that this webinar will be dedicated to the various ward round scenarios and their management. So I request you all to welcome Professor Chintamani sir. Sir, very good morning to you.
Morning.
And it's a privilege for all of us to have you here, sir.
Pleasure is mine. Thank you very much, Sukriti. Good morning to all of you. Now, I have a little request. One, that ward rounds cannot be taught like the didactic talk. It has to be interactive, which would mean that at any given point of time, if I'm asking you some questions, please answer them. I'll modify. And if you don't volunteer, it may not be easy because then I'll have to ask Sukriti to answer a few questions. Because ward rounds are essentially a two-way traffic. It cannot be just me talking about it, right? So once again, a very good morning to all of you. And this is what you all requested for. So we tried to put them all together. We compiled the cases in such a way, like we discussed during our annual meeting or when we do the scope course or when we do the Gurukul course. So we'll start with it. You're very excited for the class, same here. Very, very excited to share with you all. It's such a joy. Thank you all very much. So let's start. And we will have some ward scenarios where I'll ask Sukriti to read the case and then we'll go. Anytime I'm repeating because we need to have some bit of interaction. I'm repeating it. I will leave some questions in between and we will wait for you to raise your hands, or maybe we'll unmute one of you at one time and you can answer the question so that we make it into an uh, interactive kind of a session. And let's see how it goes, and I'm sure it will go very well and we are all going to have a good time. So let's start. The first case is that of a 26-year gentleman that is presented to surgical emergency. Can you read out the
Yes,
features?
So it's a 26 years gentleman who presented to the surgical emergency with features of perforation peritonitis. The patient had an Apache 2 score of 13 and was taken up for emergency surgery.
Right. So there are a few things here which I would like to highlight. When you get to present a ward round, because some of you who are preparing for the DNB exam would be getting it as a major part of their exam because it's a major contribution to your scores. But for the others who are doing MS or who are going for fellowships with the Royal Colleges or other places or going for the exams at local site or for practice in general, it is going to be important to know as to how do you present your case. Now, what did she mention here and what is written? Age of the patient becomes important. It's not enough to say, I have a case of perforation peritonitis. Well, that would be a very, very suboptimal way of presenting it. The patient it's a case of features of perforation peritonitis, but the important thing is the score, Apache 2 score. What does that do? It automatically tells me how good is the patient's general condition. Apache 2, Apache stands for Acute Physiology and Chronic Health Evaluation. It has some number of variables. How many are there?
So 13.
13 variables, and the score is also 13. Can you just rattle out a few of them?
So it includes the GCS. Then there are some clinical features, the age of the patient, and then the sex of the patient. Then about the mean arterial, the vitals, the blood pressure, mean arterial pressure, the respiratory rate, the temperature, and some of the clinical.
So you have chronic points
parameters.
and acute points. The chronic points are age, as you mentioned, and also the overall patient's nutritional status, although that doesn't get counted directly. Then you have acute features. It also includes Glasgow Coma Scale. So please read that, because sorry, when we put up the webinar on the YouTube, you'll get to see the scale. But what is important here is to understand that don't just mention a case of 26-year gentleman with perforation peritonitis. That won't be enough. It is actually with the score you must tell me, and then we can plan our treatment accordingly. And I generally would ask anybody who's presenting me in the ward rounds, what is the significance of the score? And your answer should be, the score is to let us know how was the patient's condition before we took her up or took him up for anything definitive. So that's important. And the the next important thing is to make sure that the duration is indicated, which is just not mentioned here, but will be described. So there are a few points missing, which I'll keep filling up. So perforation peritonitis is for how long? Because that duration would make a difference. Now, so what did I mention here? The important thing. One is you mentioned that it is suspected. Why? Based on the clinical features. So what would be the clinical features? Patient may give you history of some preceding illness, like in case of enteric fever, may give you history of maybe tuberculosis in some cases, may not give it all the time, but may give. That's why I'm saying may give. Patient may give you a history of trauma. Patient may give you a history of ingestion of steroids, NSAIDs, etc. I'm not going there. So history, a good history is important. In addition to the history, what becomes important is your examination. And when you're examining, you would find an abdomen which is tender, guarded, and usually silent. The patient can also give you a history that there were features suggestive, patient may have features suggestive of obstruction beforehand, which subsequently led to a silent abdomen. So a very loud abdomen becoming a silent abdomen would also suggest perforation peritonitis. So we must be taking a history to reach a doubtful scenario. Then you would, of course, percuss for liver dullness. Remember, every examiner, and especially the senior ones, are very happy when you mention this feature, because this is a clinical sign of perforation peritonitis, and you should then be able to demonstrate as to how do you percuss for it. Now, whenever you're percussing the abdomen, we know that, I think I've covered it. There are some videos of mine. If you're interested, you can go. Start in the second intercostal space by getting to the angle of Louis, and then percuss slightly away from the midclavicle line. You start from midclavicle line, but you don't go vertically down, because if you go vertically down, the problem would be that you will hit into, uh, say, if you go vertically down like this, these are the zones where there are bones only. So you won't be able to, the cartilages only. That is, you won't get a very good assessment. So it starts in the midclavicle line and kind of moves towards the anti-axillary line. It should be done, and you should mention, even if you've done it, it's fine, but must mention. So clinically you suspect it and you think it to be perforation peritonitis. Now score means you'll investigate based. You can't do scoring of Apache unless you investigate. We follow it as a routine protocol, and actually we manage them based on the score, which is not mandatory, although we have our own publication on this, and a lot of you have mentioned having read it. A lot of you got back on the group, which I really, I mean, going to take that into consideration. A question was asked, which I'll cover here. Would that Apache 2 scoring based perforation peritonitis management be all right for the duodenal ulcer perforations also, the other perforations also? The answer is no so far. We haven't documented it, we haven't published it, but it can be used as a rough guideline, because Apache doesn't talk about a perforation peritonitis, it talks about the status of the patient. And it is not enough to say, I found that the patient was not looking good. That is not the answer. Not looking good, you should be able to let us know how bad was the patient, and that would mean scoring. Therefore, score some way. You can use any score. A lot of people have used PPOSM, but it's not a very good score for planning the therapy. Apache 2 is also not a great score for planning therapy, but we used it. And we used it in ileal perforations, and we brought down the mortality from 40% to 4%. and we also found out where to do what. It helped, and we were looking for basically a resident proof protocol, so that the resident doesn't have to think much. Otherwise, each resident would have his own concept about how bad the abdomen is. So briefly, that is what I thought I'll discuss with you. Now the intraoperative findings, Kriti.
So the intraoperative finding, it was a single small 1 × 1 centimeter enteric perforation, which was 50 centimeter from ileocecal junction. Rest of the bowel was healthy.
And the question that is being asked is what next, right?
So I request you to write your answer. Some of you can write your answers, and some of you can also raise your hand. So anybody who raises the hand can be unmuted by us, and then the answer can be heard. Or you can just write your answer.
Unmute Naina. Okay, we'll try to save time. We are expecting that somebody would answer this, that we can then move on.
There is Naina. Mute her. I request Naina to unmute herself. You are self-muted right now. Yes.
Sir, I'll like to go as sir, for Apache score is 13. I'd like to go for an ileostomy, and also for the ileocecal valve.
First of all, Naina, you're suggesting you'll go for surgery. Would you like to investigate this patient or you won't?
Sir, intra-op decision.
No,
First, I'd like to.
No. I want to extrapolate it for the benefit of others. You would have investigated, then you would have gone in for surgery, and now that you've decided to, we are dealing with the perforation which we have given you already. I understand that we have given you an intraoperative finding. So,
Yes, sir.
what investigation, hindsight, you would have done to reach to this point?
So before the surgery,
yes,
I'd like to go for an erect abdominal X-ray and
abdomen erect, very good,
and chest X-ray. Chest X-ray, that is the standard for a perforation.
Yes. And what all investigations you would do for the Apache score that we've given you?
Sir, lactate, I'll go for an ABG testing. Lactate, I'll test, and the vitals will give me the values.
And of course, the electrolytes. Wonderful, brilliant. So you answered it, and we'll stick with you. Now, so you decided to go for ileostomy. Any reasons why?
Sir, as the Apache score is between 11 to 20, the patient is not fit for a primary closure. So I'd like to go for a ileostomy, and also with ileocecal valve, I'd like to.
That's wonderful. You like to make it incompetent.
Incompetent.
What do you do? Incompetent, Naina?
So just with the 2 fingers, I can roll the valve between my fingers and.
See, where did we mention was the site of perforation?
50 centimeter.
Towards the terminal part. So yes, you can do, one is you can break it between the thumb and the index finger, and if it was closer to the ileocecal junction, then you could push in through the stoma, you can push in a Foley's catheter, inflate the balloon and pull it. So that can also help you do it. That's I think that would please any examiner, that you're not going to simply say, I look at the amount of sepsis, which you of course would look. And I think that is more or less answered as I would want it. In this case, we are not going to do a primary closure because the score is more than 11, more than 10. Usually what Tana is talking about is our publication on this. If the score was 21, Nana, what would you have done?
So then I would not have gone for surgery, and I would have improved the vitals of the patient, put in a drain, and then waited for aperture to be less than 20 and then go for surgery.
Excellent, excellent, brilliant. That's wonderful. You would use the word optimize.
Yes, sir.
Then you provide, you'll put a flank drain. You're absolutely correct. And that will decompress partly, and you'll use the optimum support of the surgical ICU if you can, and then bring the score to 20 so that you come back to group 2, and then you manage it as group 2. I think that was a wonderful discussion on this. Now, when you're doing an ileostomy, Naina, before you do that, you've got the perforation sort of isolated. What do you do to the peritoneal contamination?
Sir, I'll wash the abdomen with
Yes,
warm
I'm
saline.
asking you the same thing. Peritoneal lavage with what? Sorry, yes, you were right.
So with warm normal saline, 0.9% normal saline.
Excellent. Yes, that's brilliant. Rather than what is the role of adding Metrogel or betadine to saline? Would that help more?
No, sir, that will lead to more adhesions, which is the most common cause of obstruction post-op. And
Excellent. And does it help? Anyway, it will not, because it has been found. If I do a very thorough lavage of the peritoneal cavity, how much saline do you think we would generally require? Your copybook
so
answer.
at least 3 liters, 3 to 4 liters.
Yeah, I'm glad you took the middle path. With your book say about 10 liters, which would mean that all your hospital would go without saline. So 3 liters is the maximum. Why do you want to use the warm saline? Why not use simple saline?
Sir, if there's any component of the intestine with the blood supply can improve with the warm
Okay,
saline.
anything else?
So that's all I can think of.
What's a major what is the major problem with most sick patients? Yes?
The hypothermia.
Yes, hypothermia. And the
Yes,
core
sir.
temperature can actually drop, which is a killer. What does hypothermia leads to the production of more of anaerobic metabolism, which will lead to more lactic acid, and it's not good. A lukewarm saline, while hot saline can damage the gut. You're very right. Any other disadvantage of betadine for a wash?
So, no, so I cannot think of. So
Okay.
adhesion.
Epitheliocyte.
It is epitheliocytal. That's very good. It is likely to damage all the epithelium, and that is why it's not a very good agent for even wounds anymore, because it'll destroy the epithelial cells and granulation tissue or healing. So no advantage of using betadine, and there is no evidence to support. Use that statement as an answer. There is no evidence to support the advantage with any of these agents.
Yes, sir.
And what one is to, it'll keep the abdomen warm, which is the core temperature will stay, because that's a core temperature. It's very important. And secondly, it will provide you the adequate washing. But if I do with 12 liters or 13 liters, Nana, what can be a disadvantage? I'm sure others are also listening, so they're also gaining from it. You answered beautifully so far. We'll try the multiple answers in the next round, because we're going to be carrying on as long as the net is working fine. Now, any disadvantage of a very thorough lavage, too thorough for comfort? What can be the disadvantage? You keep
So,
cavity. What is it that you're going to lose?
so the important nutrients and the electrolyte imbalance.
Okay,
The opsonins.
opsonins, which are protective.
Yes.
Yes.
So wash away what is the natural defense. But that's well done. Thank you. We'll unmute you. We'll mute you again, right? And you
Yes.
keep participating. Yes. We'll move on to what was done in this case, and we got one scenario. Now this is what was done. Primary repair of the perforation and loop ileostomy, which was proximal, was done. You could have done just the ileostomy also, but since the distal part could not be delivered by the registrar, so this was the question I would ask. why didn't you exteriorize? Is there any role of exteriorizing the perforation? There is a role, and we'll discuss it quickly. I'll show it to you. Sorry, I'm sorry. Now, if I have a perforation here, I have an option to repair it, bring this out as a loop ileostomy. I also have an option to bring this out as loop ileostomy, because usually in enteric perforation, you have the segment of gut which is not healthy. So it is better to make sure that you're not leaving some invisible perforations. It is said that for each one that you see, it's 10 that you miss. So a lot of these patients come back with another leak sometime later. So proximal ileostomy can be a good option in that case, because it will keep the segment without pressure. Now there is also a role of understanding. I think I can take anybody else who feels willing about planning your ileostomy and the significance of perforation being closer to the ileocecal junction versus far away from the ileocecal junction. Anybody who would like to take it?
Anybody can raise his or her hand.
There's an option there for raising the hand. This query means what?
They have written, no, sir, they have written. So please,
Anybody would
please
like
raise
to?
your hand. Who would like to participate?
They may not be finding that hand.
Are you able to find that hand? Please let us know so that we can guide you.
You've got about 10 odd cases to go. So make it fast or we move on. You don't want to make it completely didactic, otherwise that would be easy. Anyone?
Sir, we can take one by one, Ashwan. Are you all able to hear us? Can you write a yes in the chat box, please? If we are audible. So can you all see the hand?
Okay.
Oscar is also there. Yes, audible, can't see hand.
Okay, you can write if you want to be part of it. We'll unmute you. Okay, the one who said we can't see the hand.
Vinash. Vinash.
The time is important.
Like to take part, Kush. Okay, Dr. Kush, please unmute yourself.
Kush, can you hear me?
Please unmute yourself quickly.
Unmute
Yes,
yourself.
unmuted. Good afternoon, sir.
Yeah.
Unmuted.
Good afternoon. Yeah. Now, how would it matter, Kush, if I'm close to the ICJ or away from the ICJ taking this decision? Can you answer that quickly, please?
So if it is closer to the ileocecal junction,
yes,
it is a high pressure zone if the ileocecal junction is not functional in that division.
High pressure zone next.
So second thing is the contents of the ileostomy.
Okay.
If it is more close, if it is more closer towards the ileocecal junction, I'll have a longer length of bowel available for absorption of the nutrients and stuff.
Okay, that's a common sense answer. Very good. What else?
And so second thing is the adaptation, sir. If
Well, that's later. Right now, regarding your decision, what Nena said, we'll do ileostomy, and the perforation is here versus perforation is here are different scenarios. Okay, I'll cover it up. You answered it very nicely. One is it's a high pressure zone. I agree, right? And
yes,
the second is now only one person would speak. So let me speak right now. That you will speak. It may not be possible to bring it out because it's relatively fixed, right? But the important aspect is, I mean, most most perforations close to the ileocecal junction have this issue. The blood supply is not so good. Ileocecal branch of the superior mesenteric artery divides like this, and you know that one part goes to the ileum, the other part goes to the cecum, and this is the one which gives branch to the appendicular. This is the appendicular branch. Now, this area is usually with limited blood supply. That is why you people are often asked in right hemicolectomy, why do we remove the terminal ileum 10-15 centimeters? And the reason is this, because this arc is, it's not the arc of Rayleigh. This arc is likely to give a window of ischemia. So if there is a perforation here, it has different features vis-a-vis perforation proximally. In terms of management, that's what I was asking. So this would be a practical question which will be asked. Now, so you can here, you can close the perforation and bring the proximal loop out, which is also a possibility. All right. What else is peculiar to the terminal ileum, Kush?
Kush, unmute yourself, please.
uh,
Mute.
Yeah.
so one
What
thing
else?
is it is rich lymphoid tissue in the terminal ileum.
Excellent. Rich lymphatic tissue, which therefore predisposes to some specific diseases, including tuberculosis. Now, how is a tubercular ulcer perforation different from the classical enteric or typhoid perforation, please?
So the typhoid perforation,
Hmm.
it is longitudinally located, longitudinally long, and the tubercular perforations are transverse.
Okay. See that this is your teaching of pathology, which is, I mean, you must have seen a perforation. It cannot be made out whether it's longitudinal or transverse. This is what
Yes. So
pathologists teach.
main the
So
tuberculosis, it is submucosally infected, and typhoid enters through the mucosa within.
that's one point where I will give you 10 out of 10, but not for this. 10 out of 10 for that. Most of the tubercular nodules are submucosal. Therefore, when you do colonoscopy in the colon, you won't get tuberculosis easily in a colonoscopic biopsy because you only get mucosa there. But now listen to it carefully. The tubercular ulcers are classically ischemic ulcers. And that means they will have endarteritis, which will make them fibrotic because ischemia leads to more fibrosis. Now, therefore, they rarely perforate. And none of them is transverse or longitudinal. Yes, typhoid perforations can extend beyond their boundaries. The other thing is tubercular ulcers, if they perforate, we are dealing with an immunosuppressed individual because otherwise fibrosis will prevent it from happening. The other thing is tubercular ulcers also don't bleed because they're ischemic. So what when they perforate or when they bleed, we are usually looking at an immunosuppressed individual. Now, tubercular ulcers will have an abdominal presentation totally different from the typhoid perforation. We are now muting yourself. You answered it beautifully. Now, we'll call you back for participation as we move on. So this is how the two would differ, and the management of the perforation closer to the ileocecal junction versus away from the ileocecal junction would vary in this sense. Tubercular ulcers are more fibrotic, so rarely perforate. Typhoid ulcers are not fibrotic. They start from mucosa down, so they're weak. And they are actually in the pairs patches, we know that. These are basically in the terminal ileum more commonly seen. But remember, most perforations of the ileum are in the terminal part for various reasons. And the Peyer's patches they make the bowel fragile and weak. And there is also an element of what has been taught to you in pathology, Zenker's degeneration in typhoid, which is why typhoid ulcers perforate. Typhoid patients have burst abdomen. Typhoid patients have weak abdominal walls. It's all related to Zenker's degeneration. But tubercular ulcers are totally different. And then patient may give you history of tuberculosis. And of course, the appearance of the peritoneal cavity can be a dry or wet type of tuberculosis. So that's about this case. Can we move to the next part? Now, so we did this, and you may be asked as to, this will be presented by somebody. So in this case, Sukriti is presenting for all of you to, then when you start answering. And mind you, this is an exam all over in Europe, in US, wherever. The ward rounds, I'm trying to club all of them together. So it's not just the DNB kind of ward rounds, which are covered primarily. But these questions would be asked, and the answers would be as you people have done. Both Nana and Kush have done brilliantly well. So as far as I'm concerned, in their ward rounds, they have scored the marks they needed, and they can add to their score subsequently. Now with that, the first case is done. We move to the next case. Sukriti, can you read it?
Yes.
Okay, this is the patient's condition, and patient is lying comfortably.
So on post-op day 5, patient is accepting orally and the ileostomy is functioning well. The wound is healthy, but the patient is having fever spike of 102 degree Fahrenheit with tachypnea and tachycardia. The total leukocyte count is also raised, and on ultrasound, it reveals moderate collection in the right subphrenic space.
What next? Who's going to take it quickly?
If you cannot see the hand, please write in the chat box and we'll unmute you. No problem if you cannot see the hand. Just write that you want to take part and we'll unmute you.
Kush Parekh is done.
Anybody, please, quickly.
We have lots of cases, so that's why we thought we'll take. I think triangle.
This is an error, so the hand will come here. If we cannot see the hand, just write in the chat box if you want to take part and we'll unmute you. I think Srinivas would like to. We'll take him.
Yeah.
Dr. Srinivas Gedam, please unmute yourself. Yeah.
Hello?
Yeah, great. What next?
So the patient has features of local cytometry. There is a collection in the right subclinic space.
So how would you proceed?
So if the moderate collection with patient is stable, then we can go for a conservative management.
Okay, your voice is not very clear, but I understood what you're trying to say. In mute him. One is, remember, pus somewhere, pus nowhere. You know, your audio was not very good. Therefore, I had to quickly get out of this discussion. But pus somewhere, pus nowhere, pus under the diaphragm. This is a standard teaching. Now, patient has features of fever. There is leukocytosis. Your next step would be this only. You'll try and find out where is the pus. And we can go back to maybe Kush, and we will ask him as to how do we proceed, because he was involved initially. And we are unmuting you, Kush. Kush, unmute yourself.
Yes, sir.
Yes.
Now, this is what was found, and unfortunately, Srinivas couldn't be heard well. There is pus there, pus nowhere, pus under the diaphragm, and there is a collection under the right dome. That's what it shows. So, how do you proceed now? Patient is running fever.
So it is post-operative day 5 with an intra-abdominal collection. So it classifies as organ space surgical site infection.
Excellent answer. Organ space surgical site infection. What is the approach to this? OSSSI.
So first, I would like to know the culture and sensitivity of the pus
How will
collection
you
and the
know that?
quantity.
Yes, unless you
I would like to
aspirate.
do a UV guided aspiration of the collection and send it for culture sensitivity.
Excellent answer. Image guided always. We will do ultrasound guided aspiration. We send it for culture sensitivity. Yes.
So if it can be dry tapped in the same setting, I would like to completely dry tap the collection.
Great. You'll do the dry tapping. And if you've done the dry tap, what next thing you would do?
So I would like to see the color of the consistency, the color and the properties of the pus which I have obtained.
Consistency you can't see. Consistency is a palpatory finding. But yes, color and appearance, right?
Appear.
It's
Yes, sir.
translucent or turbid. How would that help you?
So it will give me an idea of the possible organisms and the source of the infection.
How? Elaborate, please.
So if it is feculent, it could be from the bowel or bilious. It could be from the a secondary perforation or a intra. Hello, sir. Am I audible?
Yeah,
Yes,
you're
yes,
very
you're
clear.
audible.
Carry on.
So if it is feculent, it can be from an iatrogenic injury which was created during the previous exploration.
But wouldn't that patient present totally differently?
Yes, sir. Or it could be, sir, due to an undrained pocket of collection. After giving washes, there would be a residual collection, and if
Yes,
it was not,
that's much better. When you're talking about OSSSI, usually it's a undrained or not unlavaged part, which is perfectly all right. So what would you do? You've done the dry tap.
and so start the patient on empirical antibiotics if he is not on any antibiotics initially post-operatively, and accordingly changed to the culture sensitivity obtained.
I think you answered it mostly. Suppose the collection was also in the pelvis. What features would the patient have in addition to what you got under the diaphragm?
So he would have a suprapubic pain.
All right,
Right.
pelvic diarrhea. Now, once
Yes.
you get the pelvic diarrhea, how do you proceed? Which one examination you'll do and which one investigation? You've done ultrasound already. You
A
also
per
can
rectal
do a,
examination.
yes, the term for rectal nowadays, coach, is DRE. You do digital rectal examination in which position?
So an lithotomy.
Very good. Lithotomy position rather than the standard SIMS position, right? Because you want it to project deeper. I mean, you want to be able to feel it. Now, what can you do in these cases? Suppose it is thick and your tap is not working and the collection is only in the pelvis. What are the options?
So a per rectal drainage can be done.
So again, rectal drainage under ultrasound guidance can be a very good method, and you can leave a drain there. It is possible to leave a drain there, hitching it to just the rectal mucosa, and with an absorbable suture, and you can remove it later on. It is a very good method of training it. Actually, if you look at the screen, that's the position of this being a male patient. That's the lateral section of the pelvis. This is the spine. That's the rectum. And peritoneal reflection is like this. Pouch, this is rectocycle pouch. Fascia of the non-bilious perineal body. This is how we are entering. And the collection is somewhere here. We can go through this route and actually drain it this way, and it can be completely extraperitoneal drainage, which can serve very well, and patient may not need anything to be done to the abdomen. And as you rightly mentioned, well answered, Kush. I enjoyed it. The the subphrenic abscess also can be drained, and we can move uh, to antibiotics based on the culture sensitivity. You should be able to answer questions as the examiner is talking to you, and the questions will keep coming out as you're answering properly. You mentioned about organ space surgical site infection, and you should read about it. This is a type of an SSI only, but it is POD5. It is related to that and very correctly answered. Now, the other important aspect is you can drain it using image guided approach through DRE, which is through the rectal approach, or you can do it through the subsequent. Any role of uh, diagnostic laparoscopy and drainage if it is needed? Yes, there is a role, but not in minor collections. So I think we'll move on.
Okay.
Yes, please.
Do you want him to unmute?
Yeah, please unmute.
Kush, Dr.
No,
Kush.
no, that's
Done. Okay.
case.
Okay.
We'll move
Yeah,
to the
hello.
next case. Yeah, Kush, you can mute yourself now. We'll just run through all the questions that I asked and the questions that can be asked in your exam. So just pay attention right now. You all answered very well. I'm starting and then all of you. So you'll be asked about these are the questions which I'm repeating here. Management of post-operative intra-abdominal collection or abscess, you should know. When does perforation occur in enteric perforation? Usually the third week. Types of ileostomy, they'll be asked here. We'll discuss it again. Complications of ileostomy can be discussed here. Then what is the high output versus the low output enterocutaneous fistula? It may not be relevant directly. And antibiotic usage in enteric fever and perforation. Now, what antibiotics are used? And most of the questions we have answered. Maybe anybody can finally take one question so that everybody participates. We can go back to Srinivas, who were probably not able to answer properly last time.
Okay, Srinivas, please unmute yourself.
Hello, sir. Hello.
Try to keep your mic right. Yeah. Now you can take the last few questions. Okay. Are you able to hear me clearly?
Yes, sir.
Hello?
Sir.
Srinivas, can you hear me?
Hello. Sir. I can hear you.
Yeah.
Hello.
Okay. Now I can hear you. Just listen to the question now. What are the types of ileostomies? You'll be asked. Can you tell us quickly?
Yes, sir. There is an ileostomy, double barrel ileostomy, loop ileostomy, permanent and temporary.
Okay, your audio is still not too good, but I understood you said one is double barrel. What is double barrel ileostomy?
Sir, can you put the both distal and proximal ends of the ileum through the same opening? Hello?
So I'll make it easy for you. Yes, yes. So they can be basically a temporary and a permanent ileostomy. This is also a method of dividing. I'm muting everybody. Temporary and permanent. Permanent is done, say, in conditions like when you've done proctosigmoidocolectomy for ulcerative colitis, then you make pouches and you do Cox ileostomy, etc. That's permanent. And it'll be invariably be end ileostomy. That's the end of it. Temporary ileostomies are of various types, and let's not make a rocket science out of it, which is what happens. See, the loop is here. I have just made an opening. Now, if I bring it out, it look like two openings because there are two openings. The rest of the loop is intact. Now, that's a simple loop ileostomy. And just because two loops are visible, that does not become double barrel. Don't use that word anymore because rarely is it done. Double barrel is related to the gun that you see with double barrels, where there is one nozzle, there's space in between, then the other nozzle. If I have space in between, like a spur of skin, and the two loops separately, that is double barrel. Then there are types of continent ileostomies where instead of getting the loop out directly, we take it out in a zigzag fashion. One layer through one muscle, then here. At different levels, it is going through different layers of muscle. So it becomes sort of a continent ileostomy. And of them, one type is Cox. There are many types. So don't get into that. It's rarely used. You would not be bothered by this too frequently. Nobody will ask you these questions. But I thought since we are talking, might as well. You can see that the content has to go zigzag, and it is a muscle splitting stoma. But the disadvantage is very obvious. Whatever is continent can get obstructed also. So the major problem is obstruction. So that's it. Now the other scenario is you cannot bring the two loops close to each other, and you have one end loop, and at some distance you have mucous fistula, which is a distal part. And this is not Hartmann's. Hartmann's is only confined to sigmoid and rectum. Don't misuse that term. Hartmann's is exclusively for sigmoid rectum. So this would be the ileostomy, and this would be the mucous fistula. If the two are brought up through the same wound, but with a spur in between, this is double barrel. I hope I made it clear. So this is precisely the definition. You can ask me later on if there's a doubt. Next case, please.
It's a case of appendicular perforation with coexisting solitary liver abscess who underwent exploratory laparotomy 3 days back. Appendectomy was done along with drainage of the abscess, peritoneal lavage, and a drain was placed in Morrison's pouch. The patient is afebrile, accepting orally, passing stools, but is draining around 150 ml of bilious fluid from the drain per day.
Now, case of appendicular perforation, and there was also a solitary liver abscess. For this, exploratory laparotomy was done, so we will not get into that confusion. And during this exploration, appendicectomy could be done, and the abscess could be drained. Peritoneal lavage was done, and a drain was placed in Morrison's pouch, or the hepatorenal pouch of Morrison, one of the dependent areas, the most dependent area in a supine position. We're not in the position in which you see the patient. Now you can see the content. They are all real cases, no imaginary case. Here are the kind of cases they're all from my ward. The patient is afebrile. There's absolutely no problem taking orally, passing stools, but is draining around 150 ml of bilious fluid from the drain per day. What do we do next? Who's going to take that question? Quickly, please volunteer so that we can move on. And all of you are good, so don't bother about ask your questions.
Please either raise your hand or write in the chat box.
There's a column. Raise your hand is the fourth column in your this thing.
In a window where you can you're unmuting yourself. Or you can just write it in the chat box. We'll take one. Okay, Chayan Gupta.
We got you, Chen. Yes, unmute yourself.
Dr. Chan, yes.
Hello. Hello.
Hello.
Yes, sir.
Yes, Chen.
Good afternoon,
Yeah.
sir.
Good afternoon.
Sir, there may be during the drainage of the liver abscess, there may be biliary communication from the liver. So I would like to go for a HIDA scan.
What scan?
HIDA.
HIDA scan.
HIDA.
This is a patient in emergency with,
Yeah.
that's why I asked you this question. There are things you do which are simpler. HIDA
Yeah.
scan is something you do at the drop of a hat. It's not always possible, right? What would
Yeah,
you
yeah.
do? You're a postgraduate in a unit. You don't do HIDA scan as the first investigation. How much is the bile coming? 150 ml. What is the possibility? You said communication. I won't call it communication, but I'll call it, it's a biliary caniculus which is injured, right? Or
Yeah,
it was a
yes,
part
sir.
of, it's draining 150 ml, and you must treat the patient, not the just the story. Third day,
Yeah.
POD3, patient is fine, afebrile, fasting stools,
Then,
taking orally. Is there any
sir, then
other option that
I
you
will,
have, or just the HIDA scan?
sir, I will wait for the drainage to come low.
I couldn't hear you. I'm sorry. That's a problem. Can you speak softly and away from the mic? Yeah.
Hello.
Yeah, I can hear you. Carry on.
Yeah, sir, I will wait for the drainage to come low. If
Come
the
low in
patient's
no.
condition is
Yeah. The page. That's what you should say. Correct. Now, patient's condition is important. No, patient is doing fine, and
yeah,
it is. Is it unusual to find these? Because the ward rounds are about the. If you can see the picture, ward rounds are about what common scenarios you face, right? So
yeah,
here you can
yes, sir.
see with my. It is draining right now, all right, but it is
Yeah,
expected to stop. It is expected to
yeah,
reduce initially. I'm not saying that you would not do
yeah.
HIDA scan at all in any cases. Suppose you've done a HIDA scan, how will it change your
Huh.
management?
Sir, it will help to confirm that there is a definite leak or from which part it is
You
leaking.
found out there is
But it will
okay, you found out there is a leak. HIDA scan is not so specific for which canalicus you're coming from, but yes, it will show you the leak.
yeah.
Fine. Next, what do you do next?
But sir, it will not help in the definitive management in this case only.
Yes, good point. Now you're getting back to it. Therefore,
Yeah,
all that is necessary to be done. We should not talk about very high investigations.
yeah, yeah.
So what I understand you're saying is, Chen,
Yes,
if
sir.
the patient is stable and it's just about 50 ml and it's only third day, it is possible that it may reduce over a period of time.
Yes,
Then I
sir.
can ask, suppose after 10 days also, it is not reducing, in fact, increasing.
Yeah.
What that you can do? Then you talk about HIDA scan. What is HIDA scan?
Yeah.
What is HIDA?
Sir, it is sir immunodiacetic acid scintigraphy.
Now you got. I would not have asked you about HIDA scan if you had not
Yeah,
mentioned it. So remember in the exam, answer things
yeah.
which are simple so that you can handle them.
Yes, sir.
Get my point?
Yeah, yes.
So
Thank you, sir.
do not buy your questions unnecessarily. Got it? So
Yeah.
we will
Yes, sir.
simply and
Yeah.
if the amount is reducing, we should not be too
Yeah.
much bothered. You know the principle of surgery or principle of life.
Yeah.
Normal passages are clear, the abnormal passages
Yeah.
close. So we will make
Yeah.
the
Yeah.
normal passage clear. So suppose it doesn't stop. Instead of HIDA scan, can you do some other investigation which can be therapeutic at the same time? Patient is fine.
Sir,
Percutaneous transhepatic cholangiography.
Or this is not something you do. Transhepatic is an invasive procedure which is going to hurt and may cause the patient to unnecessarily suffer. This is a patient who is a liver which is completely destroyed by the abscess. Okay,
Yeah.
after that, we
Okay.
are, suppose it is not settling. If it is settling, then it's okay. If it is not settling,
Yeah.
the pen is going haywire, so don't worry about it. Then we need to make sure that the distal passage is clear. So in
Clear.
one rare scenario, if there is a biliary fistula, just manage it like biliary fistula. If you do the stenting, the normal passage would drain
Sir,
adequately and
ERCP and
close on it.
stenting.
Yeah, you can do that. And this is where
Yeah.
it is draining. Or wait for it to become a controlled fistula and
Yeah.
gradually intervene. If there's no hurry, all I wanted to hear was that there is no reason to start doing everything. You mentioned
Yeah. Yeah.
HIDA, yourself
Yeah.
realized it's good, but the good news is that you retreated quickly and allowed the examiner to ask you another question. The other mistake is if you
Yeah.
get stuck with answer, it can be a dangerous scenario.
Yeah. Yeah.
Then, am I visible to you?
No, sir. It's not visible. Yeah. Now,
Anyway,
sir.
so now you can see me. So HIDA you
Yeah.
said, then you said hepatic, which is very, very invasive, right? We'll avoid
Yeah.
that. In fact, let them stop. That's what I wanted to hear. And we'll observe the
Okay.
patient during this period. What will you do? Nutrition to be taken care of, electrolytes to be
Yeah.
taken
Yeah.
care of, IV
Yes.
fluids to be taken care of, a good
Yeah.
cover for antibiotics. What will be your cover for antibiotics?
Yes.
What will be your antibiotics of choice?
Sir, initially, sir, broad spectrum antibiotics.
What do you mean by that?
Sir, like piperaceline, tazobactam, or uh,
See, you treat the bacteria, no, not the human being. So the
yeah.
bacteria is going to have which organisms? If there is a connection with the biliary tree, you're looking at E. coli and
E.
the
coli,
others that can happen with the appendicular perforation can be gram-negative organisms
gram-negative organisms,
as well as anaerobes. Will provide cover for
anaerobes.
all,
Yes, sir.
right? We
Yes,
can
sir.
wait. Finally, if we can simply do, we may not put a stent. We can simply do a
Yeah.
drainage procedure or papillotomy, which allows the distal
Yeah.
passage. If the distal passage is, you can leave it alone. It'll
Yeah.
close.
Yeah.
Every abnormal passage closes if the distal passage is
Clear.
muted. Now we are muting and we'll
Yes,
be
sir.
moving on. Well answered, Sean. And I hope you learned out of it, which is what the purpose is. And therefore, it's good to volunteer. I'm glad you did. And make your mistakes so that you can learn from them and you can move on. Now, the important thing is don't make it into a complicated disease by doing too many investigations, right? And the usual reasons for appendicular abscess leading to liver abscess are the portal pyemia. And how would this patient present? Commonly, a patient with appendicitis having jaundice suspected to be portal pyemia. Now, if there is a patient with appendicitis, all the features of appendicitis, but is also jaundice without past history of jaundice, suspect portal pyemia. The other common cause of portal pyemia, and with the kind of pictured appendicitis has in the right iliac fossa, is enteric perforation. So these are conditions which you should have in your mind and treat the patient with that kind of a cover. In any case, when you're operating, you'll have the findings. Now, if there is an appendicular abscess, very often you may not be able to do the appendicectomy. You can leave a drain there and you can come out. Appendicectomy can be more damaging if there are adhesions and if it is all stuck. But the approach is as an explorative laparotomy. You cannot do through the limited incision. It should be managed as a perfusion peritonitis case with liver abscess also, which is ruptured. So both can be managed with one laparotomy. You also have an option of doing diagnostic laparoscopy in these patients to make a diagnosis. Maybe less morbid procedures can be done, but very difficult in an emergency scenario. The other thing, the question that I asked him was basically of a persistent biliary fistula after acute abdomen. This is not a case where you will do all sorts of scans or fancy investigations. You will be clinical in your approach. And the clinical approach is fistula is due to the abscess being with a biliary cannuculus being injured, or the liver parenchyma itself is weeping, as they say. Then gradually the color will change. It will become serous. And if it is becoming serous, we know the cavity is shrinking and now it is weeping clear. And sometimes there may be a little hemorrhagic tinge to it, which is also a sign of healing. We shouldn't be worried. Finally, this should stop. If it doesn't stop, we have options to decompress the distal obstruction by doing papillotomy, which is a good option. There are other options too. I am not denying that you can put in a drain right inside the cavity. You can again do a laparotomy. These are more morbid procedures that you don't need in all the cases. So that was the part of this. So the question that will be asked, you have been answered already. Was, should the drain be placed in abscess cavity? A lot of people feel that drain itself can cause drainage. And the answer to that I'll take from any student. I'll just pick up. What else could have been done in this case? I'll again take it. Drainage is bilious. We have answered that. What are the causes of non-healing liver abscess? I'll take it from somebody. I'll ask this question and I'll cover it so that somebody can answer. Now, which antibiotic needs to be given? And what should be done if the patient is asymptomatic after 6 weeks and ultrasound shows a hypoechoic cavity? Please note these questions that I'm going to ask. And management of appendicular perforation. These are 4 questions that anybody can volunteer quickly, and we have 5 minutes for that. Otherwise, we'll be missing out on the other cases.
Anyone
No.
who raises his hand or writes in the chat box want to take part?
Okay, or I'll pick. Please volunteer. It's for you. Don't shy away from it. I've answered partly most of the questions. Okay, back to Nana. Please unmute yourself, Nana.
Hello, good afternoon, sir.
Good afternoon. Now you will take one by one. What are the causes of a non-healing liver abscess and that liver abscess which is not healing?
Sir, it can be due to any distal obstruction or ongoing infection and sepsis.
There is a
And
liver which is not draining. What would you suspect?
so that there can be a distal obstruction and
No,
the
liver
drain can.
abscess will have nothing. There will be liver abscess generally would be an independent factor. It's an independent question. Liver abscess which is not resolving. I'll put it this way. Okay, distal obstruction. What?
So the
Which type of infection can be? Which type of infection can be persistent and especially common in this part of the world?
colon. So I cannot remember as of now.
Tuberculosis.
Yes, sir.
And what else? Any organism which will also not let it heal? Any abscess can persist?
So any worms can be there, clonorchus?
Yes, worms, fungus,
Yes, sir.
distal obstruction, fungus, foreign body, and tuberculosis.
Yes, sir.
There's an article you can read on this is in BMC surgery, which is on needle being there in the liver, leading to recurrent abscesses, and it went unnoticed completely. And it was a sewing needle that Taylor swallowed by mistake. From duodenum, it created a fistula into the liver, surprisingly. Very rare case, so we had published it. So foreign body is one possibility. The other F is fungal infection. So culture should go for fungus also if it is persisting. Then it can be worms, you're right, which also produce distal obstruction, but never forget tuberculosis in this part of the world.
Yes.
Okay. Are you happy with the antibiotics that need to be given? What would you like to give? We have covered it partly.
So metronidazole I'd like to add for the appendix perforation, and E. coli, as you said, E. coli will be there. So I can go for ofloxacin or piperacillin tazobactam.
I think that's perfectly all right. Now, we would give Metrogyl anyway to a patient who's got liver abscess. You know that. So whether liver abscess or not, we'll still be giving it. Now, what is the precaution you would take if I have to tell you that this patient is also an alcoholic?
So metronidazole can cause pancreatitis.
But that is pancreas, but he's an alcoholic. Something else can it do? Something that even chloroquine can do, something that some drugs do in alcoholics.
So
Have you heard of antabuse like effect?
so disulfiram like
Yes, disulfiram is the same thing as antabuse, is the name. So alcoholic should be warned against taking alcohol along with metronidazole. And what does disulfiram actually do? It blocks the conversion of acetaldehyde to acetic acid, right? And acetaldehyde or formaldehyde, they produce blindness, problems, and vomitings and lots of problems. So this is where the disulfiram used to be acting, and alcoholic would give up alcohol. This is one drug. Or there are many drugs which produce a similar kind of a picture, and that is what is the answer to the question. Now, the third part of the question, the last part actually. Now, there is 6 weeks later, this patient has come. Patient has absolutely no symptoms, Nana, and ultrasound hypoechoic cavity in the right lobe. Should we aspirate or we should not?
So the vitals of the patient, I'd like to rescore.
Absolutely normal. Patient has normal vitals. Actually, there is no problem with the patient.
Yes, then so the size of the cavity, the hypoechoic cavity,
5 into 5.
5 into 5 centimeter. Then I'd like to aspirate. So, and but he's
It is-
asymptomatic.
Yes.
So
You
he's
please
having.
focus on Nana 6 weeks. This
Yes,
is a
sir.
very learning question that I put. Asymptomatic, previously abscess, hypoechoic cavity, only cavity. You know, stay for a long time, but patient has no abscess. You don't treat the ultrasound in this case. You
Yes,
treat the
sir.
patient. I taught in the other cases in the previous webinar. Never treat the CT. Don't treat the ultrasound. Treat the patient. Patient is asymptomatic. By putting in a needle, you will infect this cavity. Even after treatment and when everything has become all right, there may still be a cavity. Cavity would remain for a longer time than the abscess. Okay?
Yes, sir. Yes, sir.
The last question you can take. Anything different in the management of appendicular abscess?
Sir, if it's appendicular abscess, we won't do appendicectomy. We'll just put in a drain. We can go retroperitoneally and put in a drain and come out. And after 6 weeks, we'll like go for an.
Yeah, you're right. We can or we should.
We should. We can.
Yes. Appendicular abscess doesn't need to be drained transperitoneally. Now we have to go extraperitoneally behind and just break into the cavity and leave a drain there and come out. And certainly don't attempt left appendicectomy. Well, thank you very much, Nena, that you answered very well. So we move on to the next case. You unmute, you can unmute yourself. Case 3.
He's a middle-aged man, a gentleman, who presented with features of gastric outlet obstruction due to chronic duodenal ulcer.
What do you do? Patient has features of gastric outlet obstruction. What do you do next? Anybody who wants to volunteer quickly, please do volunteers. You can learn better, and others can learn from your answers also. Let's, if nobody's picking then.
Yes, sir. No, sir.
Somebody to volunteer.
Karthik.
Okay, Karthik,
You
unmute
can unmute
yourself.
yourself.
Hello. Good afternoon, sir.
Good afternoon, Karthik. Excellent. What do you do next? This is the case. Middle-aged, we're not in a detailed one, but this is a ward round scenario. So we're not having a case presentation here. He has features of gastric outlet obstruction. What would that mean? And is a case of
Sir,
chronic.
chronic, I mean, food habits could be the reason for duodenal ulcer.
No, duodenal ulcer is there and gastric outlet obstruction. How will you make that diagnosis?
Sir, to rule out gastric, whether there is gastric outlet obstruction, one erect abdomen, chest, I mean,
No,
rectum.
what history would the patient have? Listen to the question carefully. What would be the clinical way to make a diagnosis?
Oh, he will be having vomiting.
What type of vomiting?
Sir, non-bilious.
Yes, non-bilious. Or you can say it will
It will
depend on
be,
the light side of obstruction. Okay. Next,
it will be, yeah, with food contents, previous day's food contents.
previous day's food contents.
Sir, I mean, food contents, sir.
Okay. Food content. Previous day's food content is no, it's too late, isn't it?
Yes, sir. Yes, sir.
What does it take uh, for the food to pass out of the stomach?
Oh, sir, it takes 4 hours, 3 to 4 hours.
So 3 to 4 hours, you should be able to throw it back. What are the other features?
Sir, dehydrated due to vomiting.
Relax. What? No, you not answered what I wanted to hear. One is the vomiting. You should be able to describe it. Projectile or non-projectile?
Sir, projectile vomiting.
You have to say that, which comes within 3 hours of taking the.
Immediately after taking food.
It'll have the content that you have, mostly non-bilious, but if the
Yes.
obstruction is the duodenum, which can still produce gastric outlet obstruction kind of feature, it may be bilious, but mostly non-bilious. Pen is writing slowly, so I'm writing slowly. Now, there is no, and there would be other features. Now, how do you proceed next?
Sir,
What do you do?
upper GI endoscopy.
That's the first investigation you would do. Okay. Next.
Sir, electrolytes. I mean, in blood investigations, I will go for an electrolytes.
Okay, so you'll do hematological, the biochemistry, that is complete blood count and the electrolytes. Which electrolytes are usually deficient in these patients?
Sir, hypochloremia and metabolic alkalosis. Sir.
Can you speak loudly, please?
Hypochloremic metabolic alkalosis.
I think that's correct. What else?
Sir, hypocalcemia.
Yes.
And paradoxical aciduria could be there, sir.
Why is there paradoxical aciduria? That's very good. Whole theory, man.
Sir, due to dehydration, sir, actually there will be initially there will be normal. I mean, initially there will be metabolic acid alkalosis, so there will be uh, so carbon mono bicarbonate, sir. Sodium bicarbonate
Yes.
will be increased. Then further there will be then later sodium absorption along with loss of H plus occurs. So
Excellent. So compensatory it is,
to
compensatory.
compensatory there will be.
So you said you will do upper GI endoscopy first. right? But you should always mention that I'll do investigations to confirm my diagnosis, to support my diagnosis, and to treat my patient. This is how we usually teach our students. Please use that, it will help you for the benefit of all. And to confirm it, it's no harm putting in an ultrasound on the abdomen to see whether you got a problem inside the lumen, in the wall, or outside the wall. Suppose you put in a scope and the cause is outside. There can be a block from a lymph node outside.
Yes, sir.
Then you would miss out. Although we have given you chronic duodenal ulcer, but that can coexist. So it's a good idea to do an ultrasound to find out whether the pathology is arising from the stomach itself. And always good to do non-invasive test before you do an invasive test. And then you should mention about, in this case, the biochemistry is very important, and paradoxic aciduria must be discussed, and this will be asked in the exam, so you covered it nicely. And following that, we can actually also do an X-ray erect and supine, which will show you whether the stomach is distended, dilated or not. Then, of course, invasive is always done at the end. Any role of barium meal in these patients?
Sir, nowadays we are not doing very.
Why are we not doing it?
Sir, CT is better than.
Yeah, everything is better. If you have to get you something to eat, you say pizza is better than chapati. But that's not the way life is. Sometimes you want chapati only. It is what you need. It is not something you do straight away, right? Why should you do a CT if there is no need? You would exclude a malignancy maybe because the patient is only middle age, so that's not a risk involved. But CT would be required for staging. So investigations to confirm the diagnosis would be, one, you do an ultrasound, and then when you think it's an intraluminal disease, you do upper GI endoscopy, find the cause and treat it. And that's the benign cause. Now, I think we go for the second part to some other first big take, Junaid. There.
Yes, sir.
Junaid, unmute yourself. And the previous gentleman to kindly unmute himself. We've got him out.
Junaid is now on.
Junaid, are you online?
Yes, sir.
Hello?
Hello.
Yes, can you hear me?
Yes, sir. Good afternoon, sir.
Good afternoon, Junaid. Now we're moving on to the part 2 of it, which will be, I'll just a second, give me a little time with this pen. Okay, so the procedure done was exploratory laparotomy and truncal vagotomy. So what is your take on this? We have done this or we shouldn't have done it? Hello? Hello?
Hello.
Can you hear me? Can you hear
Hello.
me, Junaid?
Yes, sir.
Hello,
Yes,
I
sir.
can
Now
hear
I can hear you now.
you. Yeah, pay attention. The patient was taken up for surgery for gastric outlet obstruction, and laparotomy was done with truncal vagotomy
Sir,
and
you
gastroesophageal.
Hello.
Yeah. Am I not audible?
Hello.
Yeah, Junaid, I can hear you.
Are we audible?
Hear you. Now I can hear now. Yeah, yeah. Now audible now.
Okay, now the management was exploratory laparotomy with truncal vagotomy and GJ. That was in 5 days back. Is that the right treatment? You agree with that? Do you agree with that? Hello?
Can you all hear us?
Sir.
Yeah, I thought you can hear me. Hello? I think we will go. We'll come back to you. You can mute yourself now. Muted. Now,
Dr. Dhaval, who wants to part?
yes, let's get Dr.
Dr. Dhaval, please unmute yourself.
Dr. Dhaval.
Yes, good morning, sir.
Good morning. So we did expert laparotomy and truncal vagotomy with GJ. You agree with the treatment? Hello? Hello?
Yes, sir. Hello, sir.
Can you hear me clearly? Can you hear me
Yes, yes, sir.
clearly?
I can hear you now.
Can you answer the question, sir, please? You're wasting time. We have done exploratory laparotomy, truncal vagotomy, and GJ.
Yes, sir.
Is that
The
you
treatment given
agree
is
with that?
appropriate for the patient.
Okay. Why
Yes,
did
sir.
they
I agree
do?
with the patient. Treatment
Okay.
given to the
Why?
patient.
Yes. So listen to me now. Why was truncal vagotomy required in this case?
Yes, sir. I would prefer doing a truncal vagotomy as the patient is white. If I would see the vitals of and the general condition of the patient,
Okay.
and truncal vagotomy procedure in this patient as it is a sequelae of chronic duodenal ulcer, that is a peptic ulcer, hyperacidity.
All right. Then could we have done anything else besides GJ? Any other? GJ is a drainage procedure, no? Please speak.
Yes, sir. I would prefer going ahead with a gastrojejunostomy.
Why not pyloroplasty, which is also a drainage procedure?
Sir, as the duodenum is scarred, the first part of duodenum is also involved. So gastrojejunostomy would be a better drainage procedure as compared to just a pyloroplasty.
All right, I agree with you partly. Is there any situation where pyloroplasty is also done?
I'm not aware of the same, sir.
Good. So we do that if there is a scarring only. So scarring is not a contraindication. We will do that if there is scarring. The reason being, we are going to open up the pylorus by doing. I'm trying to write because it's writing very slowly. So please bear with me for the connection. Now we make a longitudinal incision on either side of vein of Mayo, longitudinal incision made, and we close it transversely, right? That is a simpler procedure. A lot of people like to do it, especially in benign conditions when there is a peptic ulcer disease. So you should be aware of it. We did a gastrojejunostomy because, as you rightly said, this is an advantage because you are going through an unscarred, healthy area, so the anastomosis is likely to do better. Gastrojejunostomy would be a better option. But why is the drainage procedure required with truncal vagotomy? Can we do some other procedure which would not require truncal vagotomy?
We can go ahead with a highly selective vagotomy, sir, which would not
Okay,
require a drainage procedure.
but then the patient has outlet obstruction. So drainage procedure is required anyway. It would
Yes,
not be
sir. So
needed.
truncal vagotomy would be an easier and a faster procedure as compared to going for an HSV.
Now HSV has some other disadvantages also. What are those? Since you're answering,
Sir,
so I'm interested.
sir, in HSV there is very high chance of leaving behind the criminal nerve of Gracie, which can lead
With
to
HSV or SV only?
sir, in HSV.
Okay. Why do you think that happens in HSV?
Sir, because the criminal nerve of Gracie is arises around 5 centimeters from that of the GE junction. So there are
Yes.
high chances we may miss it out, and it may lead to a recurrence of disease.
So the criminal nerve of Gracie is a branch of anterior or the posterior vagus trunk?
Sir, it is a branch of posterior vagus.
Yeah, so it can arise from the anterior also, and the highly selective vagotomy is likely to miss it out, and it is possible. Now, I'll try to show it to you on a board now, because that will be easier on a paper. so that you can understand what we are trying to say. I'll get into the important aspects of it later. Now, can you tell us something about the need for doing a drainage procedure, vagotomy? Why should we do it?
Sir, because truncal vagotomy also severs the fibers supplying the pylorus for normal relaxation.
Yes, that's very good. But where are those fibers usually located?
Sir, they are generally located near the G. They come high above from the G junction.
Okay, I'll just draw for the benefit of everybody the vagotomy that we know, and okay, I'll show it to you on a paper because the iPad writing is taking a long time. We'll meanwhile work on it also. Now there's somebody. All right, so I hope you'll be able to see it. I hope you can see this. Keep looking. This is the stomach. The main trunk divides into the left and the right, or the anterior and the posterior, you can call it whichever way. And the anterior gives off a branch which is called a hepatic branch. It supplies the liver, gallbladder, etc. And the hepatic gives off a branch which is a pyloric branch. And then it continues down as anterior nerve of Letarget, which ends at crowfoot. This is the crowfoot. And on its way, it gives off the parietal branches. It supply the P cells that produce pepsin, which is related to acid. And the posterior continues down as posterior nerve of Letarget with its branches to the celiac plexus, which is also called as solar plexus because of the look, because sun ray appearance. Now, the criminal nerve of Grassi can arise from here as well as from here, and it can go in to supply the fundus. So this becomes an important nerve which can be missed in this process, as rightly answered, because it goes parallel. But the other disadvantage of highly selective vagotomy is that it can produce, along with this, the blood vessels also go, which are end arteries. It can produce ischemic spots that can lead to formation of ulcers. So highly selective vagotomy is taxing, takes more time, and doesn't have great advantages. And the drainage procedure with truncal vagotomy is mandatory because the pylorus loses its supply. The options are, you can do pyloroplasty, which is as I described. I'm now trying to give a better picture. You make a longitudinal incision and you close it transversely. There are various types, Hineke, etc. So we are not going into the details here. Finney's, other methods. We do a gastrojejunostomy, and it is very well known that anterior versus posterior or anticolic versus retrocolic doesn't change the outcome. It's only in cancer that you're concerned that you don't want to do a retrocolic one for the fear of opening up another channel of spread. The drainage is good with retrocolic. Well, that was beautifully answered by you. And I thought, in fact, the discussion went higher because you were answering that well. Now,
Thank you, sir.
There would be some more questions which you'll be keen on answering, and I'm glad you volunteered. Therefore, I'm moving to the other questions related to it, which I've covered mostly. If this was a malignancy, would you still be needing vagotomy? Are you there?
Yes, sir. I'm there. Yes, sir. I can hear you.
Would you still be needing a vagotomy? You don't know, that's okay.
No, sir. Not in a case of malignancy.
Why? Why don't we need it?
Sir, because we are not dealing with any increased acid production in a case of malignancy.
On the contrary, what do you have?
I didn't
Achlorhydria.
get you. Yes, sir.
Considering what
Echloride.
you
Yes.
have in chloride, yes, we don't
Echloride
need it
in a
anymore.
case of malignancy.
Yeah, and a lot of people think that we don't need it at all because these days it is possible to put the patient on pump inhibitors, and you're very correct in answering that if the patient is stable then and very, very young, you don't want to put the patient on proton pump inhibitors for a very long time. That is where you do it. Since the patient fell in that age group and the patient was stable, so we went ahead and did a gastrogesinostomy. But sorry, truncal vagotomy. Otherwise, you may not do it. May not be required. So we have covered that part. Why was it done? We have covered, and the types of vagotomy. I have covered that already, and my apologies on the way it is writing, but don't worry. The drainage procedure, why it was done, was covered. Indication of pyloroplasty we have discussed. I think we have covered it up. And if anybody else who's keen, and gastrostomy versus jejunostomy, we're just extrapolating the question. What is the difference between other types of gastrostomy? When do you do gastrostomy? When do you do jejunostomy? If you can answer that. What are the indications for gastrostomy usually?
Sir, gastrostomy is usually done when we are planning to give feeds for feeding purposes,
For
especially in
feeding
patients with
purposes,
G-junction
patient,
malignancies or in head injury patients.
is it something that you see frequently done at your place?
Uh, not as a part of malignancy palliation, but definitely as a part of head injury or chronic intubated patients.
Well, I won't take it away from you, but by and large, gastrostomy is not something that we fancy these days. Can you tell me why is it not a good option?
Sir, I'm not
Risk
aware
of
of the
aspiration.
advantages of
Disadvantages
over
are aspiration, the benefit of all, and feeding gynostomy is what most people prefer. And then they can also do a peg, that they can do
yes,
a percutaneous. So it's simple these days.
endoscopy.
But yes, gastrostomy is what is done in a lot of situations. One should rule it out. But in most cases where you're going to use stomach for a pull-up, say in malignancy for esophagus, or in crico or corrosive strictures, etc., where the stomach itself may be diseased, you may not do a gastrostomy. So wherever you're going to use stomach, or wherever you think the stomach is not good enough, we may go for feeding gastrostomy. Otherwise, you can use it and it's very comfortable. There's no harm. The only risk is risk of aspiration. So that is what has taken it away out of fashion. We've done many, many, many. What are the types of feeding gastrostomy? Can you tell us for the benefit of others?
Sir, we can do a Witzeling method as well as a Stammer's method.
Yes.
Uh,
Okay.
but no procedure has advantage over either. Actually, Witzeling was initially done for the reducing the chances of a leak jejunostomy site. But both of these
Okay.
procedures have the same leak rates and same complication rates.
Do you know these terms, Bidzer and Stam, are originally the types of gastrostomy, not jejunostomy? People have
Yes, sir, they were
explored.
originally described for gastrostomy.
So, and I'll just try and draw it and show you. It is not a very good method to, I mean, we do these days putting two purse strings and just putting the outer one, fixing it to the parietes. The other methods included creating a seromuscular tunnel, which actually gets a tube in it. In a jejunum, it will narrow the opening. It will narrow the jejunum, produces obstruction. Just put one purse string and let it hang, it can cause torsion or rotation. And the classical stam was not stabbed. It will be opened and there will be a flap of uh, seromuscular or the whole wall, which will be wrapped around the tube. So it was done for permanent gastrostomies in the past. The terms have been extrapolated into jejunum, although not correctly. So you should be clear that they are not the same in both. So we have types of jejunostomies which have been modified based on the gastrostomies that we do. Both, as you rightly said, have equal role in terms of they work equally well in terms of the the drainage and the feeding, but the complication rates with the one where we make a tube or we do a flap is higher in jejunum because it will cause narrowing. And I'll show it to you on a board and it will hopefully be visible. I'm just trying to show you various types, which would be clearly seen now. And you can meanwhile keep your questions ready for the part that so here. If there is any doubt, you can ask me. Now, what they used to do in gastrostomy was very simple. Can you keep it in the center? It's coming out very. Now, now we could do a purse string and then the other purse string the other side. The tube goes in and we tie the inner purse string holding onto the thread with an artery forceps. Then we tie the outer purse string to bury it in. And that was a standard stem. But when you're doing it permanent one, what was done was they'll create a flap. Say they open up they make an opening, and at this end they will keep a flap of this disc was taken up by the flap. This was the disc here, taken up by the flap. So the tube goes in the same way you put a purse string, and then you put the tube through this flap, and we close the flap over it. That used to form some kind of a permanent thing, and it will be fixed to the skin. That would be the combination of stam and Witzel. That was done in gastrostomy. And that's where the terms became.
Excuse me, sir.
Let me
Sir, we are
finish
not able to
first.
see what you are drawing.
Now that's Witzel and stam. Now so this was the flap that we had used, which was here earlier. And we've done put the tube, this is closed. Then we use the flap to make a tube over the gastrostomy tube, and then we fix it to the skin. It used to be permanent, and after some time we'll remove the tube, and this will serve as a stoma. That's why the term gastrostomy. And you'll feed through this. This was the classical method of making a flap and getting it out. Now the same done in jejunum would obviously cause a lot of narrowing. Classically in jejunum, we would now be using, say, a loop you have decided, which you pick up at least 3 arcades away from the DJ, that you have adequate proximal part. I'm saying 3 arcades because centimeters cannot be measured. Now we will have a purse string put, then another one put. Inside it is tied, and tie the outer one, we bury it in. Now you have to bear with us because the internet connection is slow, and I'm still trying to show it. So if it comes into focus, it will show better. So, and we just tie it, and then the needle is still intact, and we suture it to the variety completely so that it gets stuck as one segment here, which does not rotate. This is the segment I'm talking about. It's come here. Now, if you just put a string and let it fix, it might rotate and cause torsion. The other thing is a lot of people make a incision some distance in the serosa and then slight distance away from it the mucosa. So there is a tunnel through which the tube goes, which is similar to what is being done here, but jejunum being a narrow tube, it can produce obstruction. So there is a problem with extrapolating what you got in gastrostomy into what you want to do in jejunostomy. So don't use these terms interchangeably, although a lot of people do that. I hope that's clear. We can again discuss it further and we'll move on to the next case. So I thought I'll take that opportunity to clarify that part also. Now, moving on to the next case. I think in this case there was one question. Are you still there?
Yes, sir, I'm there, sir.
Yeah, fourth day post-operative. There is hemorrhage in the Ryle's tube. I'll just show you that question. Going back. So there is blood in the nasogastric tube on fourth day. Don't use the term Ryle's tube. I already described it. That George Ryle had invented that tube, was a pediatrician actually. It was a rubber tubes. What we use today is nasogastric tube. Don't call it Ryle's tube. It's a wrong term. People use it, but that's not correct. What do you do? Fourth day. Management.
Yes,
Very
sir.
quickly.
This So I would like to observe the patient initially. I would like to monitor the vitals. Uh, sir, I would like to do a upper GI scopy as this seems to be a bleed from the suture side. So if an endoscopic management of the same is possible, I would like to apply a hemoclip or a sort of endoscopic management. If not, we may have to open up the patient and do oversewing of the anastomotic lines.
All right. Is it possible that the ulcer that you thought was silent has started bleeding now? Would the management change? Well, I take your answer.
Uh,
We would initially, I'm repeating it for others, just bear with me. So we'll first of all stabilize the patient. Don't just jump to treatment straight away. We will stabilize the patient and we'll make it a point that patient is uh, hemodynamically stable. We don't rush into endoscopy or anything initially. A lot of times it settles good gastric lavage using normal saline, and if it settles, then we don't need to really go too far into trying to do endoscopic clipping, etc. But those are the options which will exercise once you are looking at some patient who's hemodynamically not getting better. Hemodynamically stable patient doesn't need too much intervention. A lot of time
yes, sir.
these are erosions which stop bleeding, and if they're happening on the fourth day, they can be possibly due to what kind of a hemorrhage will this be on fourth day? Primary, secondary, or reactionary?
Sir, it will be a secondary hemorrhage.
So what is the usual cause for that?
Sir,
Reactionary, what?
either it can be
I leave that question.
reactionary.
So if it is a vessel which has slipped off, sloughed off, or the anastomotic vessel has got to bleed, is it the gastric one or the jejunal one commonly?
Sir, gastric one.
Yes. So endoscopy there serve the purpose. And many a times just a lavage can take care of that. And it is not a major vessel that is bleeding. It would have done it on first or second day. That's why I put fourth day. So fourth day is sloughing off.
Yes.
So we can wait and it might settle. So that is how you should look at it. Thank you very much. We are unmuting. You answered very well. Therefore, we could discuss so well. Thank you.
Muted.
Now we go to the next scenario and quickly cover up all of them. There are plenty of them. So otherwise we'll miss out. We'll do our best to take as many as we can. Meanwhile, please participate. There's actually no other way to go for the ward rounds. This is
So this is a case of carcinoma stomach. He's a 60 years gentleman who presented with features of gastric outlet obstruction again.
now actually more or less on similar lines. I think we've covered it. We'll do the same approach here. We'll have an ultrasound done and we can actually do the ultrasound abdomen to look for whether it's an interluminal disease, and in the same go we can then do an upper GI endoscopy. We'll do a workup for carcinoma stomach like we always do. So that is how your answer would be. Anybody who's keen on answering, I'll be happy to give you an opportunity because this is a takeaway question. Quickly volunteer if you want to.
Please indicate. Okay, Dhaval Vagadia.
Dhaval, we are unmuting yourself. Please answer this. Hello.
Yeah, good afternoon, sir.
Good afternoon, Dhaval. What will you do next? Quickly.
First, I evaluate upper GI endoscopy and do upper GI EUS to rule out the extension of the disease in the stomach, and then we can plan according to CCT for any mets is present, distal mets is also present or not, and then we can plan neoadjuvant chemotherapy.
Okay, let's stop there. Let's stop there. Now, the patient has got gastric outlet obstruction. Do you think it's an early gastric cancer or it's a late gastric cancer?
The gastric outlet syndrome, if malignancy is in lower GI area, so may present with the gastric outlet obstruction.
I'm asking you a question. It's early. It's early or late?
Is most likely is a late presentation.
So, what would endoscopic ultrasound do here? Endoscopic ultrasound has nothing to contribute in this case. So, don't use investigations unnecessarily. You'll approach the same way: investigations to diagnosis, to support the diagnosis, then to stage and treat. Because diagnosis, we'll do ultrasound abdomen to know it's in the stomach, and then we'll do upper GI endoscopy, get a biopsy, and we'll move on. To stage it, we'll do a contrast enhanced CT scan, and based on that staging, we'll proceed with the treatment. And neoadjuvant chemotherapy would be required if the patient is in a
With the
locally
G,
advanced disease, which is the response is very limited. Most of the time, the palliation is also surgery. That would have been your answer rather than endoscopic ultrasound. You don't need endoscopic ultrasound, and we are not doing metastatic workup using CT. On ultrasound also, you can see the metastasis. Where does it go usually? The liver. So, so we can find it out on ultrasound also. Now, the connection being slow, we are losing some people because of that. I hope they join back. Now, moving on to the next scenario. The procedure done was, you can stay there, Dhaval. Even
okay,
gastrectomy with Roux-en-Y, gastrojejunostomy and feeding jejunostomy was done 5 days back. Presently, the patient is afebrile, asymptomatic, wound is healthy. Okay. Now,
okay.
what is D1 gastrectomy, Dhaval?
In the D1 gastrectomy and D2 gastrectomy, in the level of lymph node we have dissected is divided into D1 and D2. In mostly the near to pyloric region, we have already always do the D1 gastrectomy with lymph node dissection up to the level 6 lymph node, and
Station 6, not level 6, station 6. Okay. So you should be
yes,
clear on that. We
yes,
will not venture into D2 and D3 in this case. It is clear the patient was locally advanced, and we were mostly just palliating it by doing the kind of gastrectomy that we did. Now, what is syndrome?
in the afferent lobe and efferent lobe, after the gastrojejunostomy, we have created two lobes. Gastrojejunostomy, proximal lobe, in which the bile duct and pancreatic duct through ampulla of Vater is opening is called afferent lobe, and distal lobe is called efferent lobes, and the and in the drainage procedure, drainage of the fluid is inadequate. And can you hear me, sir?
Yes, very well. So,
Yes.
what is dumping? You've told
In
me
the
something, which I'm listening.
yeah, in the drainage is not moving, and leads to the, I cannot convey because I'm some little confused between your answer with dumping.
No, no, don't worry. You answered it very well. The dumping can be prevented by taking care of the afferent loop not being very, very long, and at the same time, making the patient take small meals rather than a lot of meals at the same time. Similarly, the blind loop prevented, because when you do B2, that is the Bilrod 2, what will happen is you will have an element which is going to prevent it. Basically, the problems with blind loop are they could be bacteria which are static, it may cause infection and it can cause kind of diarrhea. But dumping is an issue. Now, I'm glad there one more question there, and then we'll move to the next one because we covered this part. Now, what are the complications of gastrojejunostomy? You can quickly answer, or I'll tell you. Gastrojejunostomy can stop bleeding, or it can cause bleeding, and it can also, in some situations, it can be narrow and it may be infiltrated by cancer itself. Therefore, in most gastric cancers, we do anticolic rather than colic gastrojejunostomy. And we don't want to open up the zone of retrocolic compartment for spread of the cancer. By and large, how long will you keep the nasogastric tube in situ? We'll not leave it for a long time because we don't need it. And the tube itself delays the peristalsis because the pacemaker of peristalsis is in the fundus of stomach. Audio connection. Can you hear me? Can you hear me?
Yes, sir.
Yeah. The problem is the issue with. Can you hear me?
Yes, sir.
Great. The advantage is that the problem is that in situations where you leave the nasogastric tube for a long time, and if the fundus is irritated, the ileus may not happen. The ileus may happen. So patient may have a delayed recovery from bowel sounds. I was trying to check many things at one time, so therefore I lost that thought. So essentially, you would not keep it for long. It should not be. And some of us have a practice of pushing the nasogastric tube beyond the anastomosis for initial few days so that the anastomosis remains patent, although that is not its role. The role is to drain bile initially from the loop which is not functional so that you can keep it dry to the extent you can. And when it's draining bile, it's a sign that the anastomosis is working fine. So that's about this case. I think we'll move to the next case. And thank you very much, Dhawal, for participating, and you answered well. But don't jump to answers like I'll do endoscopic ultrasound, because you could see that this is endoscopic ultrasound has a role in staging early stomach cancer, and also to find out about the lymph nodes around the stomach. So it is not really necessary in this case. Don't just say endoscopic ultrasound just because you've read it. And don't jump to CT scan unless you've done an ultrasound. Because there are situations, if on ultrasound you find the liver is studded with metastasis, you may not need a CT scan at all, because that's a disseminated disease. Or if there is ascites, then you may not need it. I hope that's clear. You answered it.
Oh.
Thank
Thank you, sir.
you. Move on to the next case, and I'll try to cover myself most of it so that we can have more of you participating. I was hoping. Now give me an answer. I want an answer. I hope you're liking this interactive way. Otherwise, I can make it didactic quickly. So please answer by writing your yes so that I know. Quickly. Okay. Okay, move to the next one. Okay.
Yes.
Now you want it this way, or we make it didactic? You want to interact? All right, we move to the next one. Why are we?
Okay, sir.
Read the next case quickly. You asked for the ward round, so that's why I'm doing it. Ward round cannot be like a didactic talk, so you have to participate. Although I'll try to speak more now than you, since you people are not answering. After these 5 cases, we'll move to the thyroid and chest and other places quickly.
So
Please.
25 years patient who presented to emergency with perforation peritonitis with an Apache 2 score of 15. Intraoperatively, a large duodenal ulcer was found in the first part of the duodenum.
So that's a suspected giant duodenal ulcer, which is defined as an ulcer with a diameter of more than 1.5 centimeters. And we have given you the score, so it helps here to know that the score is not too good. And the score being more than around 15, it's not a good case. So although we cannot use Apache to score for all perforations, primarily we use for therapy of the ileal perforations, but in this case, it is a case with a large duodenal ulcer or a giant duodenal ulcer. It's in the first part. So what do? We cannot do something usual. We cannot be putting a momental patch, or we cannot be doing standard Fontana patch. Fontana patch is where we use falciparum, falciform ligament to cover it. We can use a serosal patch to cover it, but in a giant duodenal ulcer, we need to do something different. And the options are many. These all options together are called duodenal diverticalization procedures. They can be triple tube, pyloric exclusion and gastrojejunostomy, or some people like to do a T-tube drainage. And these patients don't have a very good response to anastomosis, and anastomosis don't heal very well in these patients. So a lot of people are not very happy with pyloric exclusion and gastrojejunostomy. They don't do very well. A lot of surgeons are not very happy with that. Sorry. Now, pyloric exclusion and gastrojejunostomy is a good option if the patient's Apache score is good. But with a score like this and a giant duodenal ulcer, do not answer that. We'll put an omental patch, and that's the end of the story. So that's what we are going to do. We are going to basically, it's a surgical question, totally asking what exactly would you do surgically. The answer is we will proceed with one of the duodenal diverticalization procedures. And there are many. You can see the patient in the picture, and the options could be, many in the form of, once you find it's a duodenal ulcer perforation, you can actually find that the options would vary depending upon whether you can actually do a lateral duodenostomy is one procedure that we people do very frequently, along with a feeding jejunostomy. What that does is it will allow us to get the duodenum drained and to keep the bile out so that we are comfortable. And then we do a feeding jejunostomy here, which will be a good method to put that bile back into circulation. So a tube goes in, and the option is, I hope it is visible there only. So one is lateral duodenostomy along with the, I'm just writing on the board so that you can see. It's a giant duodenal ulcer perforation in the first part. So we have an option of keeping the duodenum dry. This is DJ and that's jejunum. Keeping it dry is called the diverticulization procedure. Duodenal diverticulization. So what can we do? We put in a Foley's here, or string here. We can guide either a nasogastric tube beyond, or we can do a feeding jejunostomy and a lateral duodenostomy. This is lateral duodenostomy. This is feeding jejunostomy. The advantage of doing this is that we can also, the bile that comes out of here, we can feed it back in. And some people like to do a triple tube, which is where you have one tube is this. The other tube is either a gastrostomy or it's a nasogastric tube. And the third tube is, it goes back retrograde into the duodenum. So the three tubes are, I'm not making them with black, so don't confuse, either the nasogastric tube, which is guided beyond, proximal jejunostomy, which comes out separately, and a feeding jejunostomy. So 1, 2, and 3. But this usually doesn't do very well. We have not seen it do very well because the lumen is larger than the tube. So there will be peritubal leak. What instead we do is we put a lateral duodenostomy which seals it completely, and we fix it to the parietum. The serosal patch also happens because this is peritoneum, which will seal it completely. And the bile that comes out, we start feeding it back into the jejunum, so that the patient has bile, which has got protective role. I've discussed it in the previous webinar. So these are the options. So don't just say, I will put in a, I'll put in a, I'll put in a, I'll put a patch there, because the patch won't work, because the patch would leak. Some people also like to do what is called as, this is the opening. So they do what? They push a nasogastric tube through it, and they suture omentum to it and pull it back, so the omentum stuffs it. But I've seen that omentum necrosis, and it becomes it's not a good procedure. They should be familiar with it. And you should not say that I'll just do the patch, which is what I'm saying. Otherwise, a lot of you would answer for us for a simple one. You can say modified Gram's patch, which means pedicled omentum being placed into position. Where if there is a perforation like this here, you put the sutures and we let it go. The patch is here, and we don't make it too tight. We start by tying this first, then this, then this, so that we don't strangulate the momentum. That's a modified Gram's patch, which is not used here. The other option is serosal patch, where you have a jejunum loop coming, and we cover this with a jejunal loop, with the serosa. These are various options which we'll talk about in making it possible to take care of a giant duodenal ulcer. Now, I'll move on. If there is anybody to volunteer, maybe we can take it at the end of it, so that we can save on time, which is important. And we have we have taken up a lot of abdominal scenarios, which is what you had requested. But I would request you all to make an effort to be part of it, because that's the whole purpose of doing the ward round, since you asked for it. Now, I would, the questions were triple tube placement, which I've covered, which is done in this case. And as I mentioned, it's not a great option, and the disadvantages are obvious. And what are the various options for management of this ulcer? I've covered it, and I think you can easily use it for the purpose that is described. So we move to the next scenario. This was a scenario of abdominal, the duodenal ulcer perforation. Now we move on, and I would request people to volunteer to be part of it. Otherwise, I'll just take it forward as I do.
So a 20-year gentleman presented to the emergency with alleged history of high velocity motor vehicle accident. He sustained blunt injury to the abdomen. There is no history of loss of consciousness, vomiting, ear, nose, throat bleeding, or hematuria. So anybody who wants to volunteer?
Let's move the complete scenario.
Right. So on examination, the blood pressure was 98 by 73 millimeters of mercury, and the pulse rate was 112 beats per minute. On abdominal examination, it was slightly distended with diffuse tenderness present. Bowel sounds were sluggish, and Apache 2 score was 4.
Now we'll keep moving.
Ultrasound fast was done, and it showed free fluid in the Morrison's pouch, perihepatic and perisplenic space with internal echoes, suggestive of hemoperitoneum.
Now, anybody wants to volunteer? What next? Otherwise, I'll move on. First of all, I hope you're able to see us. Let's get that answer.
You can have part.
Yes. Parth, you can unmute yourself.
Dr. Parth Parekh, please unmute yourself.
Hello.
Yes.
Hello. Yes, Parth.
Yes, sir.
You're there?
Yes, sir.
Please speak loudly. What do we do next?
So we'll get a CCT abdomen done. Hello.
Yeah, I can hear you. You said CECT abdomen.
Yes, sir.
Okay. You finish. You keep speaking. I can hear you.
Yes, sir. So
I can hear you. Please
first
carry
we'll
on.
first we'll resuscitate the patient as patient is
Good.
vitally unstable, and on stabilization, uh, we'll get CCT done. But if patient doesn't stabilize, then we'll have to take him for laparotomy.
Okay. Can you raise his volume? Even he can read. Now, okay. So, right. You'll first treat the patient, as you rightly said, and then you'll investigate. Now, that's one thing. And if the patient is not settling, you'll go for surgery. What incision? What approach?
So midline laparotomy incision.
Can you please increase the
Okay.
volume?
Increase the volume of your own. This thing. You're not audible clearly. Your volume is very low.
Okay.
Can you raise
Hello.
the volume? Yeah. Now it's better. So you raise it so that we can hear you. Now you speak.
Okay. So we'll give a midline laparotomy incision starting right from GK sternum up to the pubic symphysis for a better visualization.
We have done the laparotomy and the findings are on the screen. 1.2 liters of blood,
And a 4 into 3 centimeter
horizontal tear
tear.
in mesentery with active bleeding, 2.5 feet from ileocecal junction. How would you manage?
So we'll first drain the blood, clear the view for us, and as it is a horizontal tear that we can see, which should have compromised the bowel vascularity. So we'll go for resection anastomosis, but no, not resection anastomosis, sir. We'll do a stomy, proximal ileostomy or double barrel ileostomy, as patient is unstable, and resection anastomosis would
No,
hold.
what was the score? What was the Apache score of this patient?
Okay, it's 4, sir. Yeah, 4.
I've
So we
you.
can go for
4.
resection anastomosis.
And in a trauma case, the Apache score is usually good because they have no chronic illness, right? So we can
Yes, sir.
anastomose. But I appreciate that you said we'll resect because it's a transverse horizontal tear. So the vascularity can be a challenge. Well, very well answered. What else will you do? Where all you will look for the
Uh,
blood in this case? Suppose there was, I'm just extrapolating the question, there was just a mesenteric hematoma, bleeding has stopped, and the bowel is looking viable. Would you still be resecting?
no,
So
no,
how
sir.
would you consider it's a viable bowel?
Uh, we'll look for the mesenteric pulsations. We'll look for the shininess of the bowel, the luster of the bowel, then
What else?
and the peristalsis.
Yes, and I'll give you all the marks for that. Look for it and do not just rush into resection all the time because sometimes the blood supply may be adequate. But I take your point very nicely. Anybody would be happy to hear that because you took into consideration the fact that it is horizontal. You took into consideration that bowel may be devascularized. You took into consideration that we'll resect, and benefit of doubt should go to the patient. If the score is 4, we are fine. But recheck the score. Make sure that the patient is stable, and patient score is what will dictate your decision. Because if you just casually look at it, you will bring a stoma out in almost every patient, which adds to the morbidity. But that's very well answered. Section anastomosis, making sure that the Would you leave a drain or you won't?
Sir, I would leave a drain.
Why you want to drain it?
So because if there was, we
Every NS
usually do.
drain?
Yes, sir.
What is the protocol? There is no such protocol. There is no need of a drain. But there is a possibility that you would have missed out some injury, although there is no diagnostic role of drains. And most cases where the score is 4, you've done an anastomosis, hemodynamically the patient is stable, you don't see any soiling in the abdomen, there is no purulent material, there is no feculent material, you can actually leave it as such. Because drains themselves cause problems. In 48 to 72 hours, most drains get blocked. So don't put a drain to diagnose leak, which is a wrong trend. You leave a drain there if there is a possibility or there is a suspicion that there is an injury which you have missed, which is again, you should search for it. And diagnostic, exploratory laparotomy, I've described it in a webinar earlier, unexpected laparotomy last time, unexpected encounters. You must trace it from pelvis right up to the right side, that is the ascending colon, hepatic flexure, transverse colon, splenic flexure, descending colon, splenic, the sigmoid colon, and down to rectum. Exclude any other injury. And once you've done that, I don't think there is a need to put a drain all the time. And remember, drains don't function when you need them the most. But thank you. That was very well done. I thoroughly enjoyed interacting, and that's the way it goes forward. And you can also type your question if you have any at the end. Thank you. You unmute yourself. Message in the lab is here. Now, the patient had, as expected, an uneventful recovery and did well and discharged. So, well answered, well taken. I think we move on to the thoracic scenarios now. The net is a little slower, unfortunately. Now, there is this case, and I'll get Nana on. Please unmute yourself, Nana. You wanted a case like that to be discussed? She's here. Good afternoon. The case is being read out to you, and I'm sure you will take it. Keep the volume high, please. Fine. Now, read out the question. That's
Yes,
okay,
sir.
whatever.
It's a case of left-sided inguinal hernia with swelling in the left side inguinal region for past 1 year, which was reducing on its own on lying down. But for past 1 day, the swelling has become non-reducible. On examination, there is non-tender, soft swelling in the left inguinal region, which is absent cough impulse and normal overlying skin.
What do you do next? Tell us the do's and don'ts, Nana.
So it's a non-tender swelling, and
Yeah.
it is not strangulated. And sir, I'd ask for the patient patient is passing flatus and motion,
Yes.
and so it is not obstructed also, and but it is non-reducible,
It is
irreducible,
simply irreducible for the last 24 hours. It is not obstructed.
and the skin overlying is normal, and with absent cough impulse. Sir, absent cough impulse.
Yes.
So then I'd
Tell me the management now. We've got it all on the board. It's a irreducible left-sided inguinal hernia with patient having no features of strangulation, as you rightly said, and as of now, no features of obstruction. How should we proceed?
so we can try a taxes for once, and then
Okay.
we can.
Yeah.
And
Carry
then
on.
we
You
can.
finished the board.
So,
Yes.
so the last comment was not audible to me.
No, I said you carry on. You first finished, and I'll ask you. So one is
So,
taxes.
sir, I'll try to I'll adduct the left leg of the patient and flex it at the hip joint, and with the one hand over the swelling and one hand over the superficial inguinal ring, I'll try to reduce the swelling. But if it is not possible, then I'd like to go for a surgery.
Okay.
I'd like to go for a local incision.
Now I'll stop you there now. Nana, can you hear me?
Yes, sir.
Taxis has disappeared from use.
Yes, sir.
Never do taxis. Every irreducible hernia is to be treated as a obstructed or strangulated hernia unless proven otherwise.
Okay, sir.
Risk of taxis is whatever procedure you are describing. What is the complication of taxis?
Sir, it can go if the hernia is already strangulated. The
No,
toxic.
the term is reduction and mass. And
Yes, sir.
please, all if you remember it, we never do taxis. If you've seen anybody do it, he's doing something which is not with evidence. It's wrong.
Okay, sir.
The first thing is reduction in mass, which means what? You have you have a band of hernia somewhere here. The hernia gets reduced along with the obstruction. It goes in completely, en bloc. So it's called reduction in mass. It goes in completely. That's a serious problem. To the extent
Yes.
that it can create perforation in the bowel. I have operated on patients post-taxis perforation because when you are negotiating it through using some ice packs, putting the foot end up, making a chopper out of the patient, and making it impossible, it is all bunkum, no longer done. Please remember it for future.
Yes,
What do
sir.
we do? The answer is surgery. There is no confusion
Yes,
for
sir.
everybody. Treatment of irreducible or complicated hernia is surgery. Right? Because you
Yes, sir.
cannot for sure say it is obstructed or strangulated or not. Correct?
Yeah, that's an intraoperative finding.
Yes, that's different. No taxis is what I wanted to highlight here. But you can put the patient on sedatives. He
Yes,
can
sir.
relax, let him lie supine, and the hernia may go back itself. That can happen in some patients. And patient can give you a history that this has happened many times and it has gone back. So these are
Yes, sir.
patients you will put the patient on sedatives and no lifting of the foot end of the bed and making anything helicopter out of the patient. That is not done. And never Texas. So Texas is an absurd, wrong thing to do in any irreducible structured hernia. Don't get me wrong, but that is the way you'll remember it for
Yes, sir.
surgery. So what surgery should we do? You said we will make an incision. It should be inguinoscrotal rather than inguinal incision.
Yes, sir. The
And then
inguinal scrotum.
what is it that we do differently in a obstructed hernia from a hernia? We
So
open
we
the
want.
sac first.
Yes, sir. So we open the sac and see the state of the contents, the fluid, and if
We drain that out.
the
We
drain
look
the
for the
toxic fluid.
yes, and
Then
the steaming with bacteria. We can't let it go in, and we also
yes, sir.
look at the state of the content, whether it's ischemic, infected, or whatever. So no texas and opening the sac first, and we don't put a mesh because it's a contaminated field. So do's and don'ts of this case, I just wanted to discuss. Patient has been catheterized. Do you think it's a good practice?
So if we are suspecting it can be a sliding hernia, then
Excellent, excellent. 100 out of 100. You can have a slide. You may not have a slide, but these patients may have retention subsequently in the surgery, also during surgery, after surgery. It's a good practice to put in a catheter, and that takes also care of a slide in an emergency scenario. But no mesh.
yes, sir.
We'll do a tissue repair, and I'm not discussing them here. We'll have a session on groin swelling some other time. So that was what I wanted to highlight in this case, and in the ward round, this is what will be asked. And if there is any question, thank you, Nana. if there is any question from anybody, you can type it down and we can take that question, and we'll move on to the next scenario very quickly. I want to get a feedback from all of you. I hope you're all able to hear us and it is making sense. Now the questions are there on the screen. The same questions would be asked, and maybe you can answer them. What is incarceration? Nana, are you still there?
Yes, sir. So incarceration is when there is a tender swelling and the blood supply to the hernia contents is blocked. So that will.
Is it the same as?
No,
Is it the same as
no, sir, strangulated. Sorry, sir. So that is strangulated hernia. Incarcerated hernia is like irreducible hernia. So there's one
It's
difference
neither
which I'm not.
nor is it strangulated, right? And incarceration in English means imprisonment. You know, if somebody is put in the jail, it's called incarceration. And the prisoner is usually alive. You don't keep dead people in the jail. So it's a intact hernia. And it is impossible because you close the main door, the window is very small. So it is not able to come out. And classically, if you see the picture in the scenarios of the books, they show a small bowel content with the fecalith inside, which is causing the scenario. But incarceration is not the same thing as strangulated hernia. Obstructed is only when it's a lumen that is gone in. When if it is a omentum, you can't have obstruction. But strangulation can happen to all of them. And strangulation means cutting off the blood supply. There are more symptoms with obstructed hernia, but there are more signs with strangulated hernia, which you must remember. Role of texts we have discussed, herniorrhaphy, hernioplasty we have discussed. What is a phantom hernia?
No, sir. I don't have an
I'll leave
idea.
a question for all, everybody to answer at the end. I'm leaving this question for all those who are participating. Now, thank you very much, Nana. Now you can unmute. You can mute yourself. You've done very well. Thank you. Next question. Next. Any volunteer there? Go to the video. Let's get there, whether they are there or not. They're able to hear us. I think that's very important. Please reply by yes or no.
Still with us?
Can you hear us? Please type quickly. I think Chandra wanted to participate, but he's out.
This is also coming not in order actually. I'm not able to get it.
It's a fresh question. Can you hear us? I think we now move to the chest. This is okay. You can do this one quickly.
18 years gentleman who presented with chief complaints of abdominal pain for past 2 days, high-grade fever for past 1 day, and multiple episodes of bilious vomiting for past 1 day. There is history of blunt trauma to the lower abdomen sustained in a fist fight. On examination, his blood pressure is 100 by 80 millimeters of mercury, pulse rate of 108 beats per minute, and respiratory rate of 18 breaths per minute. He is febrile with 101.2 degree Fahrenheit. On per abdominal examination, it was distended and tense. There was generalized tenderness with guarding and rigidity. No organomegaly would be appreciated. Percussion showed no free fluid in the abdomen, and auscultation revealed absence of bowel sounds. These are the laboratory investigations. Hemoglobin is 13.7 and TLC of 8700, platelets 75,000 with LFT, KFT and the electrolytes with the normal limits, ABG also with the normal limits, and the Apache 2 score of 1. The partial pressure of oxygen is 88.5 and saturation is 99%. This is the chest X-ray.
What next? Who's going to volunteer quickly? We'll move fast. Let's take somebody who's willing. Yes.
Dr. Ashish Kamatham, please unmute yourself.
Ashish, are you there? Can you hear us? Hello? Ashish, are you there?
Please respond, Dr. Ashish.
We're not able to hear you clearly. There's some sound.
Dr. Ashish, are you there? Can you please write if you can?
Let's go to some.
Dr. Amok Pathak, please unmute yourself. Dr. Amok Pathak. Dr. Amok, please unmute yourself.
Okay, it's taking long and we'll be stuck otherwise. We won't be able to do more cases. Now you can look at the X-ray. I think you can go to somebody who's volunteering. Other people.
Hey, Dr. Ashish, can you hear us?
Why don't you speak, Dr. Ashish? You're unmuted. Hello? Hello? Save time. We'll miss out. Anandi.
Dr. Anandi Andappan, please unmute yourself.
Dr. Anandi Adappat, can you unmute yourself, please?
We can have the same Dr. Dhaval.
Okay, Dr. Dhaval.
Dr. Dhaval Vagadia, please unmute yourself. Yes, sir.
Okay, Dr. Dhaval, you're there.
Yes, sir.
Yeah, what next? You can see the X-ray and tell us quickly what do you do next. The last
On
abdominal
the
case, then we have to move to chest. Yeah, quickly.
on the X-ray finding, no any air fluid level is seen, or no gas under
Okay.
diaphragm, and on the chest rib cage, no any chest wall injury is also seen, and
Okay.
slightly ground glass opacity seen in the abdomen. Uh, I want to do USG fast for rule out the collection,
Okay.
any abdominal collection in the Morrison's pouch or pelvic cavity.
Okay.
And sir, asking the history of patient to passing flatus and stool to see the their bowel mobility and bowel viability.
Yes.
And then the according and after the USG report, I can proceed further.
Actually, would you like to look at the X-ray chest again? I'm just expanding it if I can. We can't expand it. So something here.
I could not be differentiate.
This is looking like a normal abdominal appearance, or it's a glass appearance?
It's a ground glass appearance, so might be hemoperitoneum is suspected. I have to on the X-ray basis.
No, but look carefully. The X-ray quality may not be very good, but you can still look for. Can you look for some gas under the diaphragm? Look carefully.
Yeah, sir. On the left side, I have to slightly guess on the diaphragm.
Now, does it make a difference to your approach? You've already got history of trauma.
Yeah. So
in
in
the
the
central
guess
part.
on the diaphragm, so I have to plan the exploratory laparotomy. Due to the Apache one, so I can patient is stabilized, so I can proceed the patient to OT and exploratory laparotomy and see the bowel perforation or any
Yes. I'll tell you the findings. You agreed on laparotomy. So it is moving slow. That's why it's taking a little time. I don't think I'm.
Abdominal examination also revealed that there is peritoneal.
The abdominal findings were there, which we discussed with you. Did you listen to them carefully? The feature suggestive of the liver dullness was also masked. So you should listen to the story carefully. And intraoperatively, there is distal ileal perforation, 1.5 into 1.5 centimeter.
Which is 130 centimeter proximal to the IC junction, which was repaired primarily. Another proximal perforation of 0.5 into 0.5 centimeter, 160 centimeters proximal to IC junction, which was taken out as loop ileostomy. The patient underwent exploratory laparotomy with peritoneal lavage with double barrel ileostomy and primary repair of the distal perforation with drain placement.
Now you can see I presented to you a contrast. If the patient has a score of 1, you would do a closure. Why should we do exteriorization? It's not necessary, but it can go wrong. It's a scenario which is different from what normally we teach. If the score is less than 10, why should we do an ileostomy? It is actually required. That's where
yeah.
you're taking the decision. Get
But,
the point? Your answer is
yeah.
correct.
Yeah, two perforation and patient is presenting with the gas under diaphragm and alleged history of trauma. So might be we can take an ileostomy.
Why? How will ileostomy help? We have 2 perforations. They can be repaired. The principle does not change. If the patient is going to heal. If the score is good, we can close. So although this is what I presented this case, put it up for you to understand that you don't need ileostomy all the time. Sometimes we overkill by doing an ileostomy. This patient could have been managed by, if the perforations are very close to each other, we have a segment which can be resected and we can do anastomosis. But they're 0.5 into 0.5 centimeter and 1.5 into 1.5. So both can be repaired. Problem here was it was close to IC junction. So this is why there was one of the perforation was taken out as ileostomy. Be so defensive in these cases, especially trauma cases with a score which is good. We should be able to go for primary repair. Well, thank you. You answered well. We move on to the. You can unmute yourself now. We go to the next cases, which are related to. Now
Thank you, sir.
Now patient has developed burst abdomen on day 7. Now listen to this story and.
The patient developed burst abdomen on post-op day 7 and had mucocutaneous separation at the stoma site with stomal retraction on post-op day 20 and leak from the distal perforation site. To reduce the fecal contamination of the abdominal cavity, temporary approximation of the proximal and distal loop done and laparostomy was made.
You will see the picture on the screen when it comes. Case was different from what we imagined. It's not a case from our institution. It's been considered for board rounds in the scope course also. But I have different questions. This is day 15, and you can see the patient's appearance.
Right is the caplet side and left is the caudal side.
Right? So
yes.
That's a picture. Next. What do you think has happened?
In that due to the trauma, some bowel injuries occurred and is not look like the perforation, but a damaging of the vascularity. So they lead a perforation after that time sometimes. This one might the possibility.
That's one possibility. It you're talking about missed perforation or impending perforation which was missed. That's absolutely correct. What else can happen in a patient who sustained trauma? They can be the viability of the bowel could be doubtful, which can also produce that picture. So the investigations are shown, and stick to that, and then we're not. So what Oh, there's one possibility. So what is it that we can do?
And a second possibility is platelet count low. So might be patient develop the DIC and causing embolism and causing the ischemic lead.
That's too far. That's too far fetched. Don't think about it. The easier one is more common. Don't think of DIC leading to for DIC will cause bleeding. So there's no history. DIC is conjunctive coagulopathy, so it will be bleeding also from the wound side, from the catheter side, etc. That has not happened. And don't go by this picture. This picture is suggestive of sepsis, and you missed a perforation, and now you have to manage this patient as an open abdomen and hope for the best. And you can look at the plastered abdomen. This patient was referred to us. We didn't know was much to be in this case because we can't intervene. So we try to do we manage it as a laparostomy with wound manager, and we can do a tube ileostomy. That is, the tube goes into the perforation that can drain the contents out. So there is you have to manage this patient as an infected patient now, other than just looking at the wound. The management would be management of the patient, management of the wound, and then the other things. You would need to be assessed for infection, would need to be assessed for where all are the leaks. The problem with contrast CT in these patients is oral contrast leaks from all over. You don't get a very good picture. The collection would be happening all around. This patient has to be managed by using wound manager and regular washes. And the outcome is dependent on patient's general condition and nutrition. The patient needs a supplementary nutrition. Patient needs not TPN. What's the disadvantage of putting patient on TPN completely?
Hello, sir.
What is the disadvantage of putting the patient on TPN?
Is causing metabolic disturbance in their
Mainly
metabolic
the
electrolyte
stage balance and
and
villus atrophy, stasis of the bowel, which lead to cholestasis and then jaundice, and then you won't be able to give it also. One thing. Secondly, the gut is not used. So I often say this to my residents: guts, use them or lose them. If you lose them, if you don't use them, you lose them. So enteral nutrition is always better. But there are situations where you cannot really hope that you can provide it through the enteral route, but as much as possible should be provided through the enteral route. So we'll put it as SPN, supplemental nutrition. So we'll have this managed as a wound, and we will use, and I'm using cursor to show it. Wound manager would make sure that it'll be, I hope you can see it, that this is where the wound manager will collect all the feculent matter that is coming. And we can also use temporary abdominal closure techniques to make sure that we allow, with the topical negative pressure therapy, the wound to heal, the contents to drain outside. So thank you. That's about the burst abdomen part that somebody was asking. Now we move on to such chest cases now.
Yes.
We'll have some quick videos to see, and you can actually, after that, we'll take questions. We're going to wind up immediately after that. Please pay attention to this case, and I'll pick up. Anybody can start writing answers. This patient had
She's a 60 years lady who presented with history of bullhorn injury one day back, and on examination the patient had tachypnea and tachycardia with difficulty breathing, and so maybe
so actually with the we just see the video with the audio. I'm speaking there. Yeah, just keep. Okay, we can stop. Now, you can volunteer for this. Must ask whether they were able to see.
Were you all able to see the video? Please let us know, indicate it in the chat box. Yes, sir, they were able to.
Okay, who would volunteer for this case now? Well, if you want to know, this is a bullhorn injury of the right side of the chest, elderly lady. Her respiration looks all right. We put in a chest tube. We were checking for any bronchopleural fistula. There was no gas bubbles, and patient was by and large managed by observation and chest tube drainage. And this is a classical case of hernia of the lung. So it's not. It doesn't need any. The lung is still breathing. I mean, everything is fine. The chest wall has got damaged. You should not treat it by aggressive surgery in the beginning. Patient can be managed by simple supportive measures. And is there any need to apply any pressure padding on the hernia? The answer is no. Patient can breathe all right. Now, we asked somebody who has raised the hand.
Dr.
Ashish, can you answer that?
Good afternoon, sir. Can you hear me, sir?
We are coming to you third time. I don't know why we are not able to connect you.
There's some
Ashish,
problem
yes.
with the microphone, sir.
You're okay. Now I can hear you very well. Now you saw the video?
Yes, sir. The video was slightly choppy. I could not make out the video properly.
Okay, then you volunteered. You raised your hand, so I thought you had seen it. Well, it is a case with a chest wall injury where I was very clearly demonstrating that on Valsalva, it was appearing there was a defect in the chest wall, and it was cuff impulse also visible. We made a diagnosis of lung hernia of the lung. Right? How should we manage it? I already mentioned that. Can you add something to what I spoke, or if you didn't hear it, you can tell us what you do.
You, like you said, there's no place for aggressive surgery here. It is a case of lung hernia. We can just support the patient, give conservative measures, give a good oxygen therapy, give good pain control mainly to make sure that if there are any ribs broken, give her a transdermal fentanyl patch, and rule out flail chest if any.
There is no flail because the lung is free. The lung is, it's just that the wall is gone. You get my point. So you very rightly answered. Pain management, active chest physiotherapy, and by ruling out a bronchopleural fistula, which I did by showing you the cuff test, there was no bronchopleural fistula. The patient may need nothing except this supportive treatment. And maybe at a much later date, we can do the fixation of the chest wall, but not right now. And no aggressive surgery is actually indicated. Now, especially when you're putting in a chest tube, we put it in the triangle of safety, taking care that we don't puncture the lung, because that is one thing you should not do. And very carefully we'll put in a chest tube. But you're right, we'll not do any aggressive management. Right? Anything else you want to speak?
Sir, what is the definitive management for the hernia per se? Are we going to bridge the defect by using some kind of prosthesis?
Excellent question. Now we have to look at the size of the defect. If the size of the defect is more than 4 centimeters, 4 is an arbitrary figure. Can you see me and hear me?
Yes, sir. I can hear you and see you as well.
Yeah. So if the defect is more than 4 centimeters, I'm delighted because you can now see what I'm writing. Now, if the defect is large versus the defect is small, we can just approximate the ribs and the pleura would take care of itself. But if the defect is large, like in this case, this is large, we may need a prosthesis. Can you see it? The prosthesis we create by using a mesh Usually, earlier days, I've used composite mesh, but you can use any biological mesh. But importantly, we use what is called as cyanoacrylate. So we make a sandwich of mesh in between, one layer above, one layer below of cyanoacrylate. So it becomes kind of a plate, and we suture it to the edges. And that's because otherwise it will always remain a flail segment. It will never be contributing actively. So we need to stabilize the chest wall, but not immediately. Since your question is good, so I went that extra distance to explain. Now, the other thing which you can look for is the if the pleura is intact, which is usually the case. If the pleura is intact, so if the pleura is intact, it just goes off as a hernia, and the chest wall is broken. That is how I demonstrate the cuff impulse and Valsalva here. Now, in that case, you can just push the pleura in and pad it for the time being. I demonstrated that also, that the swelling was reducible, and on cuffing it came out. So at a later stage, we'll use a prosthesis, which I've also described just now. This will be cyanoacrylate. Is that clear?
Yes, sir. Thank you.
Yeah. So, very well answered. And actually, we'll do everything that we do for a chest wall management. What is running of the system in relation to the chest tube? Can you tell us what exactly do you understand by the running of the system? There is a rib here, got a chest tube in place. What do you understand by the term? This will be very commonly used. Running the system. What is that? What do you mean by that?
I'm not aware of this term, sir.
Yeah. So if you see the column is not moving, we usually attribute it to either the blocking of the tube or the lung is expanded or both. So, or there is a hole in the tube somewhere which you can miss. So what do we do in this case? We never clamp a tube. That's a wrong thing to do anytime. The only time you should clamp a tube is when the patient is being shifted for some investigations or from one room to the other, and then you remember to take it off. The important aspect is not let it be there for a long time. Now, running the system is you apply multiple clamps, one after the other. You walk the tube, the leak is. And if the leak can be excluded, or you can find a leak in the tube, then you need to replace it, or you can sometimes seal the leak, because that can be the cause. The air leak can happen. So therefore, running the system is the term used for looking at the possibility of a block in the tube, or a possibility of a leak in the tube. Right? Now, suppose there were gas bubbles coming in this case. When I was doing the cuff test, what would you have done differently?
If there were gas bubbles, sir?
Yeah, in the water bottle, when we ask the patient to cough, there are gas bubbles. It indicates bronchopleural fistula.
Bronchopleural fistula. Yes.
What do we do? What do we do in that case? Same patient.
We observe the patient expectantly and see if the number of bubbles or the volume of air coming out from the ICD reduces over a period of time. More often than not, the bronchopleural fistulae come down over a period of time, and no active intervention is usually necessary. If the patient is deteriorating, if there is some signs of infection, or if the bronchopleural fistula is increasing, we would need to explore the patient actively and go ahead and do something to the fistula and close it.
Any investigation before that, which you would need to have before you can say what you're saying? You're right. We look at the number of bubbles. We see the patient's condition, because we treat the patient, not the tube again. And if the bronchopleural fistula is getting, confined, we need bronchoscopy to actually grade them. Right? You can also do CT of the thorax to know for the size of the fistula. If it's a small one, you can seal it endoscopically also, or from outside. You can use VATS to seal it, or sometimes you can use the cross sutures if it is a small one. And most of the time, as you rightly said, it stops. So I've given you all the options. That these are the questions that will come out of a case like this. Management of the chest tube is something which is always asked, and we have tackled it. Most questions I've tackled as I've gone along, so there'll be very few questions at the end. Maybe we'll have one or two more cases and then we'll wind up. So this is what was expected of you in the answering, and you answered it beautifully. Thank you very much, but stay tuned. I'll call you for some other next case also maybe. Thank you.
Thank you, sir.
You can mute your. Yes.
The next video, sir.
Please watch the next video. Muted. It's a case of trauma, as you can see, and there was a sign you saw initially on the face. Now we are asking to take a deep breath. What do you observe? Taking it down to the chest tube. Now, volunteers or answers. Anybody would like to volunteer quickly? We're running because we took a lot of time asking you people to volunteer. That's why the webinar has gone beyond its routine time. Anybody who wants to come in? Anybody? Yes? Well, it's a classical case of, if you're not volunteering, then I'll take it quickly. It's a classical case of chest polytrauma where we have a panda sign which is present, which is that you have blackish discoloration around the eyes, which is periorbital collection due to anterior cranial fossa injury, which was there in this case, and along with a flail chest. Now, I'll pick up Ashish only because he's there fresh. How do you manage this case? Ashish, are you there?
Yes, sir, I'm here.
Ashish, can you hear me?
Yes, sir, I can hear you. I'm here.
Yes, Ashish, can you hear me?
Yes, sir, I can hear you, sir.
I see that you're there. Can you hear me?
I can hear you, sir.
Okay, then we go to the next option, that is Asit Chakravarti. Yeah.
Dr. Asit, please unmute yourself.
Yes, sir.
Asit?
Yes, sir.
Hello?
Sir, yes, sir. I can hear your voice.
Can you hear us, Dr. Asit?
Yes, sir. I can hear your voice.
All right, so this was flail chest. We'll not waste time because then we'll run out of cases. Flail chest. The management was what I was trying to ask you. I was thinking this would be a case for you in the exam, so somebody should volunteer. Can you hear me?
Yes, sir. I can hear your voice.
Hey, yes or no?
Please unmute yourself if you can hear us, Dr. Asit. You could hear us.
Ashish again.
Yeah, Dr. Ashish, can you hear us?
Yes, sir.
I can hear you, sir.
So Ashish, can you hear?
I can hear you, sir. I don't think I am audible.
We cannot hear you. Hello?
All right. We just
Hello. Hello.
The flail chest is when you have fracture of 2 or more than 2 ribs at 2 or more than 2 places. So naturally, you have a segment which is flail. This is the flail segment. The flail segment would make it a paradoxical respiration because the segment is not a part of the chest wall anymore. And when it is flail, we need to manage it by usually management of the patient, providing him all the trauma-related ATLS protocol, which we don't want to discuss here, and then IPPV, which will serve as an internal pneumatic splint. The lung would be, the respiration would be controlled by the machine. The chest wall would move as we want it, and that would help in making sure that there is no paradoxical respiration and the whole chest moves as one. And when that happens, the respiration automatically settles. The other advantage of IPPV is the control is in the hands of the machine. So IPPV is the standard of care. There is no evidence to support the early fixation of flail chest. And the ribs can be allowed to be as they are. And the rest of the management is pain management, which was covered in the previous case. And overall management of the patient is what is necessary. I think we'll take more questions now rather than discussing the other cases to discuss. But since we are not getting the answer, so yes, some answers are given in the form of writing. Yes, very good, Divang, Dipyang.
Mansi Patel also.
Mansi Patel has also answered. Expected treatment management advantage of adding gastrostomy with the intention. We'll get into that. So that's the management of this case where you can participate in the discussion beyond this. Now we'll have one more case, which is retrosternal extension of the thyroid gland, which probably we can take. There's no other video.
There's a one more. This one.
Yes, please see this. I'll have again one of you participating. I think I'll have Nana. So Nana, unmute yourself, and we will unmute you also.
So can you hear
Please
me?
watch.
Good afternoon, sir. Sir, can you hear me?
Now, this is a case of the polytrauma. And Nana, are you there?
Yes, sir, I'm there. Can you hear me?
Can you hear me, Nana?
Yes, sir, I can hear you.
Now, can you see the video? Well, don't bother about the sound. Yes. So this is a case of polytrauma, and you can see the ribs there. The chest wall is all gone. Tell us about the management of this case.
Sir, I'll manage the first according to the ATLS
Nana, can you
protocol,
hear
the
me?
vitals. Yes, sir, I can
Right,
hear
we can't
you.
hear you. Now you speak, please.
Sir, can you hear me? Sir, am I audible to you?
Now better.
Yeah, so first I'll maintain the vitals of the patient according to the ATLS protocol and
Right.
check for airway breathing, circulation, and if the patient is vitally stable, and as it is a penetrating injury to the chest.
Yes.
So is the patient vitally stable?
It is actually, yes, you can carry on. Now you can see the chest wall is all gone.
Yes, sir.
Now, what can you do beyond the routine protocol that we already discussed? So we will not get into that part. Would you like to fix the chest wall in this case?
No, sir, not as of now. As the patient is already vitally stable, I'd like to put him on oxygen and clean the wound and avoid any infection of the wound and dress it up.
Okay. You see the video, I mean, you must have seen in the video that there is some movement which is abnormal here. So, contrary to what you saw in the previous case, this is an open wound, isn't it?
Yes, sir.
There is a wound here. You need
So
to do
I can,
something here.
sir, I can wrap it. So I can put in a chest tube and close it from 3 sides. And
So, chest tube, now this could be contaminated, so we may not fix it immediately. But what do you do when you have the compound fractures in the long bones? We do external fixation, don't we?
yes, sir.
And we keep the wound dressing. So there is a possibility of doing that in these cases, and which is what we did here. They were fixed using the steel wires, but the wound was left open. So they stabilized it. So somewhere you can stabilize it. It's not always a steel wire that you need. You can also use simple number of protein through periosteum. Just keep them together. The other thing is you can also stabilize by using an external support, which you probably were referring to. Once you got the external support in place, the wound can be managed because the wound is there. That was the difference here, unlike in the previous case. So
Yes,
the
sir.
open wound managed with good antibiotic cover, regular dressings, and of course, you need to support the skeleton because if the movements keep on happening, then the healing will not happen.
Sir, and the
This is
chest
where
tube
it is different.
will be put through another
Chest tube
opening,
is
right?
definitely, and that's what I was going to ask you. Glad you asked. Where do you normally put a chest tube all the time?
So usually we put it through the same wound and close it up with 3
No,
sides. But in
no,
this
no. Chest tube is always put in the triangle of safety. We
kind
don't
of so,
bother about. Okay, and that is bounded anteriorly by the anterior axillary fold, posteriorly by the posterior axillary fold, and the fifth rib below. There is
yes,
no
sir.
confusion about chest tube would be put, and we in any case never put a tube through the wound that we are trying to dress. No drains are put through any wound, so we will not use the chest tube through the wound. Okay,
Yes.
this wound
Okay.
will be just ribs will be just put together so that we have a supported we have a support to the wound, and then we'll manage it by regular dressings, antibiotic cover, and hope for the best. When the wound is granulating, we can cover it up we can mobilize the skin from around, or we can put a graft or a flap. That is what we will be doing in this.
Yes, sir.
You have a question?
No, sir.
Thank you. You answered it, and we are winding up the. There is one more case. If you are keen, we can take it. And if you all are keen, then I can get a yes in the screen. Otherwise, we'll move to the question answers. If there are any questions, we'll take.
Yes.
Ask them if they're still there.
If you have any questions, please post them.
Are we moving? No. Ask them yes. No.
Please reply in yes or no if you have any questions, or should we move further?
We move forward. They are hearing anything.
They are hearing us, sir. So can we move forward? There are some questions.
I think we'll take the question, and part of it we'll take later on. Otherwise, it will be okay. We'll take the questions first.
So the one question by Dr. Harshvardhan is, why no mesh in irreducible hernia?
Okay. You can give me the screen to write on. Harsh, I don't think you attended earlier lectures of mine, or you've been part of the ward rounds in the past. Remember, I said the first thing, any patient with irreducible hernia I need to write any patient with an irreducible hernia needs to be treated as potentially obstructed and strangulated. I hope that is clear. We'll take your questions. Don't worry now. We'll take more questions now. That will be better. Irreducible hernia has to be. Anyway, irreducible hernia has to be taken as strangulated or obstructed or whatever. That's why we are doing surgery in emergency. When we are doing surgery in emergency, where are we operating? We are operating in the emergency OT. What is happening in the emergency OT? Lots of emergency cases. So it's not a clean OT. It's not a clean surgeon. It's not a clean team. No mesh, no prosthesis if the OT is contaminated. So the answer is any patient with strangulated hernia, no mesh. And any patient who's taken up in emergency, no mesh. This is the recommendation, that protocol that I'm trying to teach you. There are situations where you can get away by using mesh. Infection may not happen. But as a rule, the standard is no mesh, because it's a contaminated environment, field, and a surgeon. Next question. What is the difference in surgery between
When we are dealing with a sliding hernia?
Well, that's a good question, so I'll take it. When we're dealing with a slide, you should know what is a slide. Slide is when one wall of the hernia is formed by a viscous. Simple, no confusion. So if I was to draw it, I can only draw a cross section, one wall, not all walls. So one wall is, okay, I'll take blue color. This is the wall. This is a viscous. Now the earlier treatment for this used to be, you make a cut here, we open it, we make a cut here, and what do? We push the contents in and we close the two ends. So we extraperitonealize the content. This was called reperitonealizing the sac. This procedure is no longer done. It's very cumbersome. We have done it. It used to be done. It's mentioned in the book. The management is reduce the sac along with the slide, because that doesn't change the outcome. The management is of the, you're going to provide a repair to the posterior wall. So this is not, length of hernia doesn't make a hernia recurrence. High dissection rather than high ligation. So I'll dissect it as high as possible and push the whole thing down along with the slide, and then do the posterior wall repair. So that's a management of slide. What is running of the chest tube? I'll repair it.
Yes, sir. Please
The
repeat
chest
why
tube
the
is
clamp in the drain.
the problem with, not in the drain. The question, the statement was, we never clamp a chest tube. Please understand it properly. Now, we never clamp a chest tube because it can lead to spontaneous or otherwise a pneumothorax and can kill a patient. And sometimes you've seen when there's gush of blood, people just don't want to see it, so they clamp the tube. That is not a good thing to do. You should let it drain. And running the system means you're just looking for the possible leak somewhere. So what do? I clamp here with my fingers or some instrument, clamp here. See that there's no leak. Or you can do a water leak test. That was called running the system. And we don't clamp it because it can precipitate the respiratory arrest in these patients, or can produce picture-like spontaneous pneumothorax, which is therefore not tension pneumothorax. I'm using the word constantly. It can produce tension pneumothorax, and we don't do that. Or hemothorax, depending on what you have. Next question.
Sir, Dr. Shiva, what exactly was meant by Witzel jejunostomy?
Well, I think I've described it. I'll go into that later. We'll take those questions which are new. Most people are asking for more cases, but a question, then we'll go. The volunteers are there. There's so many volunteers.
No, sir, we took them.
What shall we do?
Yes. Um, so that's all I think.
No.
No, they were answering.
Okay.
So what do we do when hernia reduced on OT table after spinal?
That's a very
Dr.
good question. Just stay there. You can now see the board also. Who has asked that question?
Dr. Suman.
Suman, that's a good question. If it reduces under spinal, visible there?
Yes.
Proceed with surgery as before. But the question can be extrapolated. It reduces on its own in the ward. In the ward, this patient needs to be observed for 24 hours. For what? Same thing that I was discussing, reduction in mass, because it may manifest in 24 hours. So that's the answer to your question. Can we go to the next one?
Yes, sir. The next question is by Dr. Shiva Kamesh. Sir, sac is open at the fundus or the neck, often asked by our seniors. Never understood.
Always is always wrong. That's one thing you should remember. But it is opened mostly at fundus, and it does matter. You should not open at the neck, because if you open the neck, the contents will go in, and that will be a disaster. So that's a sac. I hope that is clear. And these are the contents. I hope you know that is the neck, which is usually at the deep ring. We open where? Here. Drain out the contents, check for the loops, and never at the neck. Perhaps having said that, it is not fundus always, because you can open somewhere here. But fundus is the ideal site to open it. I hope that is clear. And the contents will be inspected for before they're allowed. This is the last part to be opened at the neck, because if it slips back, then you're allowed the strangulated bowel to go in, which is not the right thing to do. Next question, please.
The next question is by Dr. Somebody was asking to kindly explain the incarcerated hernia again, Dr. Aditya.
See, if I have a hernia which is irreducible, not obstructed, and there is some fecal matter here which may once in a while block it, and it will get relieved. So incarceration basically means, it's a term very commonly used in infants. So it's not a commonly used term, so don't use it. It may get obstructed, and incarceration is mostly indicative of imprisonment. And a prisoner is usually alive. We don't have a dead prisoner. Prisoner would be alive and in a cage. So it's a living bowel. You can manage it by, like I said, anytime it is irreducible, you can do a planned surgery, unless the patient is coming with acute symptoms like the case we discussed. And incarceration is not synonymous with strangulation. Please understand that. Because strangulation would mean the prisoner is dead. The which is not the case in the prison. Incarceration means in prison.
So how will you manage pantaloon hernia by Dr. Adnan Khan?
I'll manage it as any hernia. This is the pantaloon hernia. That's the inferior vessels. Please watch some of our models that we have put. A lot of effort went in by seeing that. We prepared models for hernia. You should watch it. This is the epigastric vessels, and obviously somewhere here is the also the deep ring. So the hernia is too large. What it decides is to go this way, part of it, and this way. So the same hernia, I'm sorry. So it's the same hernia, which has gone this way and has gone this way. It's a hernia only. What I would do is I lift to the deep ring, get the vessels, ligate it, cut it, and then it becomes one hernia, treat it like any other. What is holding it like a pantaloon is the inferior epigastric vessel. So it is a hernia lateral to it as well as medial to it, which is what this is the triangle of Hasselbalch. One part is coming out of here, the other part is coming out of here, like a pantaloon. So you will repair a posterior wall like we do. We can use the lichen stent mesh hernioplasty. This is the triangle of Hasselbalch. So part of it is coming here and part of it is coming here, but the hernia is one of mind you. Okay, so we have a part here, we have a part here, and it's being blocked by this. So we get these vessels off, it becomes one. Usually I'll do a shoulder ice in these cases.
Sir, Dr. Yusuf Jan was asking role of pyloric exclusion and gastrogenostomy in giant tumors.
I think I took that,
Yes, sir.
but I'll show the drawing. The picture was not working that time, so I'll just show it again. This was the giant renal perforation. What do we do here? We make a small opening in the stomach, and through that we put a purse string using vicryl sutures. Some people use proline. That closes the pylorus with purse string inside, and we use the same opening for gastrogesinostomy. That's pyloric exclusion and GJ. So this is the exclusion, and this is the GJ. This naturally involves an anastomosis. If the patient's general condition is not very good, we don't find it doing very well. So what we would now our concern is this anastomosis, which if it heals well, I usually will adding feeding J along with it anyway, the plan B. And if it is, and this can be, then you can do whatever patching. I would put in a Foley's inside, inflating it, and hitching this to the parietal, which will make it a parietal serosal patch of the peritoneum. And then this bile that comes out, I can feed it in. So lateral duodenoscopy plus, I'll create an extra corporeal shunt, which will feed back the bile, and over a period of time, this would be removed. I'm not talking about PEGJ. PEGJ I've already described. Next.
So Dr. Navya has answered about the phantom hernia. It was the bulge of muscle tone, muscle due to paralysis of the muscle.
Excellent answer. With the weakness of the muscle, something on the lines of Malgagny bulges, you can get the phantom hernias. And this is just by the way. Who has answered?
Dr. Navya.
Dr. Navya. What is she's complete answer? Read out loudly.
So she has written phantom hernia is bulging of the muscle Due to paralysis of the muscle. Bulge of the muscle due to paralysis.
Not paralysis, weakness. That's why I want to highlight. But that's well answered. Next.
So next,
Okay, another 5 minutes to go, so we'll finish off with the last question. We wanted to cover up some more cases. We'll take them next time.
the management of Spigelian hernia by Dr. Asit.
Well, it's Spigelian hernia is where the inferior epigastric vessel is entering into the rectus sheath. So there is a hernia which is to be managed by, you can do it laparoscopically, or you can, usually there is an absent posterior rectus sheath in the lower 1/3 of the, the junction between the, draw a line between symphysis pubis and the umbilicus, the vessels enter here. There's no posterior rectus sheath here. So this is the weak point which hernias can happen. It's managed like any other hernia is reduced, and we repair the rectus sheath as we normally do. Any other questions?
Sir, Dr. Suman is asking that in the lateral duodenostomy, tube is coming out through the same duodenal port.
Yes, because it's too large to be closed. And even if you close it, it'll open up. So this is kind of a bailout procedure. Good question, Suman. What it does is, this is an opening. How do I close it? No suture will work here. So what we do is we put in a Foley's to inflate, and inflate to a level that it gets kind of, cozily sutured. And then you put couple of sutures only. But we don't take duodenum to the wall. We bring the wall to the duodenum. So it gets covered. Some people also like to do one more thing in addition, which is very good. That is, they put a T-tube into the common bile duct. But you can understand this dissection would be a challenge. That takes all the bile out. So then you can do whatever procedure. Because most other procedures usually fail here. So it's through the same perforation. You're right.
So Dr. Siva Kamesh is asking if you could kindly elaborate on placing a drain retroperitoneally via McBurney incision.
That's another good question, relevant. What do? We have made an incision which I have taught people to make it a little lateral to the lateral to the McBurney's point. I go a little lateral because in any case I don't want to hit, and this is my classical approach. McBurney's point incision, you hit the small bowel loops, they'll all be popping out and they'll bother you. So what do? Instead, I make a little lateral incision, which will make me go to the cecum, which is what I want to do. Mine incision is just about 2 centimeters medial to the antisphenic spine, which is this here. And I'll keep going through the skin, then the external oblique, then I'll cut through the transversus abdominis. I will not split these muscle fibers because I don't want a rat door or rat trap drainage. And then I go behind without opening the peritoneum. Behind, I'll go with my finger and I'll puncture the abscess, drain it, drain as much as I can and leave the drain there, but I'll bring it out through another opening, and this can be loosely sutured, not the muscles. You can even leave it open.
So Dr. Swatej is asking if hernia turns out to be strangulated, whether to do resection anastomosis from inguinal incision or whether to do laparotomy.
That's a very good question. Who's asked?
So Dr. Swatej Singh.
See, the answer is, if you can do it, then through inguinal incision. But it is difficult mostly because the gut is edematous and you've resected. Then if it slips back in, you're in trouble. So it is advisable that you go through the midline, low midline, and do a proper anastomosis. But after you've resected. So resection, I'm repeating, through inguinal incision only. Anastomosis to a midline laparotomy, ideal. But rarely, if the part is very small, if you can do it through the inguinal incision, absolutely no problem. But it's not usually, it's possible but not probable, as I say. Possible but not probable. This becomes an option. But resect before you go into the abdomen.
So what would be the ideal fluid for resuscitation in gastric outlet obstruction by Dr. Harshvardhan?
You answered yourself. Now we've lost lots of chlorides. The patient is already in alkalosis. Naturally, it will depend on what is the status of the patient in terms of acidosis and alkalosis. So fluid is to correct it. You will be giving acidotic fluid. Having said that, don't take Ringer's lactate as acidic. It is alkaline because Dinger's lactate changes into soda bicarb kind of a thing, or an alkaline thing in the liver. It's an alkaline solution. So patient is already in alkalosis. He lost lots of acid. You'll replace it with sodium chloride initially. And it's not a very difficult acidosis to correct. So don't get too much dragged into it. End of the day, some people would say DNS, because you'll have to give some dextrose, but I would say isotonic, that is normal saline, to replace to take care of the alkalosis. But there are other aspects to look into it, which is a long discussion where you need to take into account the electrolytes also. And usually under stress, we don't give sodium for too long because sodium is retained in stress. So patient has got sodium, and along with that, fluoride would be there. So we don't give too much of sodium in the immediate postoperative period or patient under stress because sodium is being retained due to secretion of aldosterone or steroids during stress. So taking that into consideration, but we will be able to make it a point to correct the alkalosis.
So next, Dr. Kush Parekh is asking that if a truncal vagotomy with GJ versus Bilrod 2 for the chronic duodenal ulcer and scarring.
I think that part was covered.
Yes.
Still there? No, wait a minute. I have a doubt. Can you go back, please?
So here.
Read it. I think that I've answered. So basically, the GJ, if there is scarring here or no scarring here, that's one option. Because this is obstructed anyway. So we are bypassing obstruction, and because we are doing gastrojejunostomy, we're taking care of truncal vagotomy. These are the two things which you need to look at. If you're not happy with pyloroplasty, the other option is you can do pyloroplasty, get the scar tissue removed, and close it transversely. Naturally, this is more cumbersome, easier to do, more likely to fail also here, and we need to have a good drainage in these cases. And GJ is a fairly simple and very quickly done procedure, along with truncal vagotomy, which we have covered.
So this you had answered in the previous webinar.
How to avoid
Adhesions in
postoperative
the
adhesions in peritonitis cases. I think we discussed it last time. That is, I'll repeat it, meticulous tissue handling is something you should remember. Not too much of lavage with hot water. And using less of diathermy. There was a case about it, which we'll take later on. You don't have time. Less of use of diathermy because you'll produce ischemic spots and you may burn it. And some people say the dust in the glove, which is a powder that you use, has also been found to be responsible. You should never let it drop in the peritoneal wound. And then the best option is prevent it. A lot of people have used Dextran 70 and other agents to reduce it. But I think a tissue handling, less use of diathermy, not tying too much tissue, not burning too much tissue, all this can prevent adhesions. In spite of that, adhesions may develop. And we should not produce ischemic spots, which is the major cause of formation of adhesions.
So Dr. Anandi is asking for post-op bile leak. Can MRCP be an investigation?
I think there was a bile leak case. We'll cover it up in the next webinar. But MRCP is not the best investigation because it will show you nothing. You basically need, a lot of people feel that CT is a better investigation for the collection. But ultrasound will guide you. MRCP can just let you know in a later stage whether there is a site of leak from where the anatomy could be abnormal or whatever. But ERCP has a therapeutic role in addition to diagnostic. So ERCP is what a lot of people prefer to do. I'm not saying MRCP has no role. What I'm trying to say is, relatively speaking, CT is very good for collections, and MRCP for the biliary tree, and ERCP for the therapy. Damage control surgery, Asit Chakravarti. Well, you answered the question very well, but probably you could not be audible. So I appreciate that answer. And I think that takes care of most of the questions.
Yes, sir. Sir, Dr. Harshvardhan, chest tube was put for hemothorax. After day 5, the output is sanguineous, 30 ml for past 2 days. Patient is asymptomatic, vitally stable, but X-ray is showing CP angle blunting and mild effusion. Can we remove the chest tube or any role of pulling out of the tube and refixing it?
Well, that's a very, very important question, very commonly asked. Now, the most important thing is how is the patient hemodynamically, clinically, and how is the chest. Sometimes the blunting can stay for longer time than you want, right? So if the patient is respiratory wise, respiration, the air entry is good, everything is fine. Now, there is a case for pulling the chest tube, but then that was a case when the chest tube was directed in one direct way. Nowadays, we know the action is capillary and it's got nothing to do with where you put it. Do you put it in the same triangle of safety all the time? Both hemothorax and pneumothorax. If the patient's general condition is good and if the content and the amount, as you're saying, is less, and if it is serosanguinous, it's drying up, I'll remove the chest tube, but I'll get a chest X-ray done before that and chest X-ray done after that. And we can keep the patient for a day under observation.
So Dr. Kritika is asking if we can wait for, if the patient is asymptomatic and irreducible hernia, can we wait and post as elective case?
Well, that's another good question. It can be if the elective surgery happens the next morning. We can't delay it for too long. My answer to the question was it's an emergency surgery. Where you do it is not what I said. If you're operating on some VVIPs and you have a patient with irreducible hernia, you will get a main OT open on that day. You can put a mesh. But my reasons for not putting a mesh were that if there is an element of infection, you just had it and can't mess with mesh. It can be a horrible infection. But you can wait and for the elective OT in an irreducible but asymptomatic patient. If the patient is symptomatic, you take it as obstructive. My problem is I cannot say for sure 100% that this irreducible hernia, which has happened, is an acute phenomenon in last 6 to 8 hours, is not obstructed or strangulated. I cannot say by good clinical examination also. I'll know it on tape. They're investigations, but they're not very, very sensitive. But if you think it's just an irreducible hernia, which has been there for 4 or 5 days, patient is comfortable, we can do it in the next OT that we can get in elective scenario. And then you can manage it as an elective hernia. Many a time, people have irreducible hernias and they carry, there's a loss of domain. People have a scrotal abdomen also, they continue to live with it. So it depends. If the patient is symptomatic acutely, you have to treat it acutely.
So Dr. Harshvardhan is asking if in a burst abdomen with intracutaneous fistula and surrounding skin inflamed, and patient is not affordable for the costly stoma bag because the size is required is bigger, and the skin is slippery due to inflammation, and any idea how to manage the situation and low cost management options to protect the surrounding skin from
I'm
leak?
surprised you did not watch the last webinar or you don't remember what you watched. I had shown you the use of super glue, which is nothing but Fevikwik. It's FDA approved, which works very well in the peri wound area. Use that and it will be helping you in the sticking of the Eurobag zipper laparoscopy, which again I showed you last time. I think this I had addressed last time. I find this egg white business nonsense because it stinks and it doesn't help. And all the other creams are fancy and expensive, as you rightly said. We use Fevikwik, and please read my article on super glue in laparoscopy or stoma. You can find it on PubMed. And also on zipper laparoscopy, you'll find an answer, but you can use it.
So most of them.
Yeah, so I will just elaborate on this further. Now, peri stoma or peri burst abdomen, we apply the super glue, which is Fevikwik. The only precaution we need to take. I have a request. Please don't forget what you were taught last time because it's a lot of effort that goes into it. You should always revisit the webinar. It's for your reason and your interest that we do it. And it is not that there is any other interest involved here. So it's for you to go through the previous lectures and webinars to appear like a good student who should be asking more questions. There's no problem in the question. We apply super glue which sticks to the skin and we don't have to remove it. The only care you need to take is wear glasses because the vapors can be harmful to the eyes. Apply it and leave it there. In 7 days, when stratum corneum comes up, it gets peeled off on its own. You don't need to peel off. And it forms an impervious layer over which the contents can fall. it's a pity if somebody is thinking that we'll just post it on the YouTube and you will be watching this webinar then. I think it's a waste of an effort. Don't be lazy about things. You should attend it live, whatever it takes. So, and it is going to be benefiting you only because I covered up most of the parts relating to abdomen and thorax today. We'll take up the other parts maybe next week. So I hope you enjoyed it as much as we enjoyed getting it to you. Now, if you could just post yes there, we'll know that you saw it. And at the same time, it was our pleasure to bring it. And we did it because a lot of you were asking for the ward round cases, and we made them extrapolate into the theoretical discussion also. So if there are no more questions, we already run time. Could you just indicate whether you're there or not? Because that's what is important.
Five nine. Thank you.
Right then, thank you very much. And all the very best to you. We hope to see you next week. And I think the concluding part, I'll leave it to Sukriti to tell you as to how you can. We'll not upload it immediately because that's one thing which will make you lazy and you would not be watching, which you should. So I'm glad I'm getting all those responses. So thank you very much and have a great day. Enjoy your day. It's a Sunday for us too, mind you. We kept it for you. So hopefully you find it useful. But do go through the webinars regularly when it actually is happening so that you are actively involved in it rather than keeping it pending till it appears on the YouTube. That is a sign of a very lazy professional and he's not going to benefit much out of it. Thank you.
Thank you
And
so
thank you,
much,
Sukriti,
sir.
for putting
No,
it together.
sir, thank you so much for the valuable time and also because the internet connection was not fine. You
That's okay.
used the board also and thank you so much, sir, for teaching us.
Pleasure and thank you for watching. Hopefully we'll catch up with you next week. God bless you all. Thank you. Thank you.
Thank you so much.